Good morning, I'm Wesley Eplin, Director of Health Equity at Health and Medicine Policy Research Group. Thank you so much for being here. My gender pronouns are he, his, and him. Welcome to the Chicago Forum for Justice and Health Policy, Health Reform Impacts, Challenges, and the Future. Thank you for joining us today. We're here to discuss health reform and to discuss such questions as how do we make our rather messy healthcare and health insurance systems work better to support people? How do we make our county, our society, fully honor the human right to healthcare? We'll explore these and many other questions with our many panelists. For those of you who don't know Health and Medicine Policy Research Group, we are a nonprofit independent policy research and advocacy center focused on advancing health equity for all Illinoisans. The organization was founded in 1981 by Dr. Quentin Young, a fierce health and social justice advocate. How many of you have been to a health and medicine event before? How many of you, is this your first time? Great, well, welcome to the newbies and thank you for returning, those who've been here before. Thank you. I want to express our gratitude, our thanks to the Washington Square Health Foundation for their generous support for our research and of this event. We also thank our co-sponsors, the Loyola University's Beasley Institute for Health Law and Policy and the Civitas Child Law Center. So they help us out with this beautiful space and room, and we're very grateful for that. Next, I want to take a moment to appreciate my health and medicine colleagues for their teamwork to make today's forum possible. With us today, Karen Loda, Morgan Higgins, Claire Thatcher, Madison Hammett, as well as our Executive Director, Margie Schaps. So thank you all for everything that, these forums don't just happen on their own. It takes a lot of teamwork, a lot of behind the scenes work on communications and the like, and logistics to make it all happen. Can we get a round of applause for all of our different supporters? We'll announce our speakers later as they come up for each panel, but I want to thank each of them also for taking the time to prepare and be with us today. As a heads up, CAN TV is here today. Thank you to them for recording and for later broadcasting this event, so you can share with other folks who couldn't be here with us today. And I didn't forget, I want to thank you all, or wish you all a happy Halloween, and thank you for being here on a snowy Halloween. Now, before we get to a discussion about healthcare and the safety net, I want to take a few moments to discuss a crucial public health topic, and that's equitable public education. Now, this is important, and you may have noticed it's been in the news a lot lately. On behalf of Health and Medicine, I want to express our solidarity with and appreciation for the Chicago Teachers Union, AFT Local 1, and SEIU 73, whose workers, our teachers, nurses, social workers, support staff have been fighting for an equitable, a just education system, and to really rethink our city's budget priorities with regard to public education. We stand with you in the fight for education justice. And we know there's a strong relationship between education equity and health equity. And the struggle for education justice is a fight for health justice. I want to explore this a bit more and note that the social determinants of health framework centers power as the main mechanism by which communities demand that government provide for their human rights. And this strike reminds us of the critical role that power has in the distribution of money and resources to support people's health and well-being. And as a reminder of the crucial role that organized labor and our unions play in fighting for a fair and just society. So I bring this up because we, as a broad health sector, don't talk enough about or engage as much as we need to with building power with communities who are demanding justice. And so when we say we're focused on the social determinants of health, we need to talk about that. If we're serious about the social determinants, we need to focus on building power with communities making demands for their basic needs and human rights. Right? Right. All right, so again, we stand in solidarity with education workers and are confident that they will be able to return to school soon with real gains for our children and our communities. And social determinants of health came up quite a bit in our research, which we'll be presenting shortly. I hope that we can discuss today how we can shift the relations of power and fight systems of oppression together, which also came up in our interviews and focus groups. Before I get to that, I would like to review our agenda. Right after the welcome, we'll do a presentation on our preliminary themes from our health reform research. So you'll be hearing from me on that. Following that, we'll have 3 moderated panels with Graciela Guzman from campaign. She's the campaign director of Healthy Illinois Campaign, and she's also a board member of Health and Medicine Policy Research Group. I'll leave it to her to kind of introduce each of the panelists later, but we'll have one response panel made up of state government, one from the provider and insurer perspective. I should note we did have someone from an insurer who's going to be here today. They couldn't make it. They let us know yesterday, so I'm sorry about that. And then for response panel 3, we'll hear from health advocates. We'll have time during each panel for some Q&A from our moderator as well as with the audience. Is Luvia here today? Luvia Quinones, I think, is on her way. She couldn't make it first thing, but we might kind of mention, and there's a flyer in your packets on public charge. So this has been in the news a lot, and this might come up during our panels, but just wanted to mention that public charge rule is currently blocked from going into effect by several judges' decisions blocking it. So that's a victory. It took a lot of people pushing hard against this rule, this draconian attack on particularly on immigrant communities and their families. And so that's blocked. If you want training, you can reach out to ICER. If you want to hear about public charge and kind of what's on the docket moving forward from ICER, Protecting Immigrant Families. I think the Shriver Center is doing trainings as well. So we might invite Luvia up a little later to talk about that. All right, next I'm going to go into my presentation. I'm going to go through this very briefly. You all have a four-pager handout, and it's the stapled document in your packets that goes through. And these are initial findings that I've prepared along with my colleague Sharon Post, who's been working with me on this. So I'm going to go through these. So it's a brief outline. We go through the key questions of our research, a brief discussion on our methods, and then I'll walk through our initial draft themes. As for key questions, we really do this research to think about kind of how do we monitor the impacts of health reform and thinking about the unintended consequences, right? So what's happening that we didn't plan for as we advocate for change? And then how do we react to that? How is the health system overall reacting to that? And then what do we need to prioritize moving forward? I'm not going to read through this list of questions, but that's really the gist of what we're trying to ask about when we sit down with folks. As for methods, we talk about, we collected data from December of last year through May of this year, conducted key informant interviews with several people at hospitals, FQHCs, community-based organizations, and at insurers, and then a couple of focus groups with community-based organizations. Recordings were transcribed, and coding has yielded initial themes, which we're about to review. Unsurprisingly, one of the overarching things that came through loud and clear was that there's been a huge positive impact from the Affordable Care Act and Illinois' Medicaid expansion on the Cook County safety net, and importantly on the patients who benefit from access to care. Certainly a lot of unfinished business of health reform and a lot of remaining gaps and those unintended consequences I mentioned. But overall, people are, who we spoke with were very pleased, obviously, with this expansion, and of course are continuing to try to grapple with what that means, right? It's a big adjustment to have hundreds of thousands of people who haven't had insurance before get insurance. So how does the system respond to that? How do we help do that? And at the same time, around the same time, Illinois was moving patients into Medicaid managed care, right, which is also a big shift. So our draft themes. One of the overarching messages I would get when we conducted our interviews and focus groups was that the system is complex and that there's a lot of remaining inequities within the system. And it was really difficult, and that you see these together because they really are two separate subjects, but because they're kind of overlapping, right? People grappling with a system that doesn't quite work with regard to insurance or with the way that healthcare is delivered, while also grappling with deep inequities in our society and within healthcare. In terms of patients and families' experience of system complexity and inequity, folks talked about significant portions of the population served by the safety net remaining uninsured and underinsured. And this might sound obvious to our group, but along with that, the threats to stable access to insurance that people's needs, and a lot of those are at the federal level, that those changes are things that stress families out, that make people question whether or not they're going to have insurance. And of course, people do lose insurance, which we'll talk about within that complexity. Safety net patients endure the effects of the inequitable distribution of the social determinants of health, which we talked about briefly before. Those include things like housing, food, transportation, jobs, and economic security, and of course, safety from violence. And I think that this is just so crucial that we keep that in mind, that we live in a very wealthy society with great wealth and resources, and yet so many of our people are going without what they need, the basic needs in the hierarchy of needs. So that's really important anytime that we talk about health reform, to keep that in mind. And within the context of systems of oppression, these attacks, the heightened attacks from federal officials, have bred distrust, fear, trauma, and confusion, as well as withdrawal from care, or withdrawal from signing up for insurance, right? That's something that came through loud and clear in our research. I think it's also important to think about our health workers, right? Because they're the ones providing care, and they're also dealing with the same system and from a different perspective often. So health workers' ability to provide care is shaped by that complexity. And the overwork and significant job stressors from this is something that also came out frequently. So the burnout was something that we talked about in, I think, every interview, every focus group. And there was this general sense of a lot of clinicians feeling like they couldn't provide all the care that was needed in a visit. That has to do with certainly the people's biomedical needs, but also with unmet social needs, which we talked about on the last slide, right? So the other piece that came up quite a bit in this research and our prior research studies on this is that the 15-minute visit, which seems standard within FQHCs, is wholly inadequate for providing the care that patients need, and just puts a large amount of stress on workers, but also on patients who then have to do more return visits than they maybe would otherwise do. Now, there's no clear way of changing that except investing more money into FQHCs, right? Because the amount of money that they're getting from the feds really boils down, and the number of people that they're supposed to see boils down to a 15-minute visit, right? So it's not something we can just snap our fingers and say, make it a 30-minute visit. We need to, again, give back to that demand for the money that they need to provide the care. Another thing that came out of our research was that many of our health workers also have unmet needs, and that includes healthcare as well as unmet social needs. People talked about the stress of having high debt from be it medical school or other education to be able to even practice within the safety net, and that then is contributing to turnover, where people will go to other jobs where maybe they can get a different higher paying salary. So they train within the safety net and then leave the safety net often. And that's not everyone, but some people do leave the safety net, and so there's this constant recruitment and retention issue for our providers. The hostile political climate, this came out frequently, the attacks on immigrants, and there's, of course, this is not new, right? It's, I think, felt as heightened under the Trump administration, but we have an impressive society. We have never had a fair and just society in the United States, and so there's the baseline oppression, and then there's the more explicit rhetoric under the current administration and their supporters, and that comes out in terms of how people feel. People talked a lot about electronic health records. This comes up a lot in terms of people being able to access information and being able to exchange information across institutions. The lack of equity, diversity, and inclusion that are within our safety net, and our safety net reflecting the communities who are served was a major issue that came up as well, and certainly a lot of attention paid to it. But we have to change. Going back to my prior comments on education, we have to invest at an early age such that we can even have a chance of people being able to access jobs in the safety net. And then this issue of unpaid or low-paid family caregiving for people with disabilities and people who are elderly and need the support. I remember one quote from our research, somebody saying that sometimes these caregivers are dying before the person who they're giving care to, right? And that it's a high burden, high stress job, and it's low paid, or often unpaid for family members. And then finally, this issue of competition within the health sector for workers, right? So you get competition from managed care organizations and also from different, among hospitals, among FQHCs for a limited number of workers, and the broader issue of health profession shortage areas came up as well. Redetermination. Redetermination came up, I believe, in every one of our discussions as well. Certainly a lot of frustration with the way that they're handled in the state of Illinois. People reported great dysfunction with that, a lot of patients losing their Medicaid coverage, even though they were eligible for it. We'll have an opportunity, I believe, to talk about that during our panel discussions, but I think it was one of the biggest pieces that came out and that adds a lot to our complexity also, and kind of unnecessarily adds to the burden both on patients and on providers, and then organizations having to staff up more than they would have to otherwise to deal with that. So you see this quote of somebody saying that they were wanted to buy a fax machine for the state of Illinois to deal with the Medicaid applications. So the other piece I wanted to raise is that safety net provider organizations also experience this system of complexity and inequity at the organizational level. So people talked about the impact of the Illinois budget impasse, that we lost some of our safety net organizations and workers, and you can't just flip a switch and get that back, right? It doesn't just come back after the money starts flowing again. And that some of these organizations and some of these workers won't come back. They left the state, or they left the workforce, and they won't be back. Closures and mergers was another major thing that people talked about. I would say that that's something that we've seen certainly in the Cook County region of hospitals closing and the loss of the jobs, and real concerns about loss of an anchor institution within a community that depends upon that, as well as the access to care that it provides. And so kind of how do we plan for that? How do we think about that? Staffing and workforce issues challenge our safety net institutions with regard to recruitment, retention, and maintaining what they list as their greatest asset, their staff. I mean, that came up, I think, we asked about what do you see as your greatest asset? I think everyone said our staff, our dedicated staff, right? So this issue of burnout, this issue of recruitment and retention, this is critical that we get at that because our staff, meaning our workers in the health institutions, are the ones providing the care, and if that's our greatest asset, what are we going to do to support and protect that asset? A lot of comments from our research talked about managed care implementation and the complexity that has come along with that. So folks talked a lot about contracting, credentialing, and prior authorization, as well as billing. Folks talked about MCO denials for care that they insist would have been covered under fee-for-service, and that they also insisted was necessary, right? So a lot of haggling with insurers over what they're going to cover. They talked about shifting of contracts, shifting of what's reimbursable, and that adds the complexity in questions, right? Because you have you have a number of patients coming with different managed care organizations, and that those contracts that they have with other providers, with what they're reimbursing for in terms of prescriptions, those things are changing as well. So kind of a moving playing field for everyone. Folks talked about that MCOs, in spite of their contracts, do not consistently meet language needs of all enrollees or the specific needs of people with disabilities. The last point on this, many providers remain interested in the promise of managed care, meeting the triple aim, but they noted that there need to be some rule changes at the state level, so I hope we get into that during our panel discussion. We also are very interested in funding and philanthropy. The complexity facing the safety net complicates the role of funders who must decide. Sorry, I need a drink. All right. Thanks for that. The complexity facing the safety net complicates the role of funders, who must decide where in this densely layered system to intervene with targeted investments. And so this focus on new or innovative initiatives, a lot of folks talked about that funders are very excited about, let's fund something new, right? But they also don't necessarily have the funding for the thing that they've been working on for a long time, perfecting, evaluating, and that is working and just needs to be scaled up, a pilot project or something that has been doing for a while. Folks talked about the often laborious process for grant applications, which was noted is often for very small amounts of money, which that could be made to be more efficient. We have a number of ideas on how that could be done. Folks talked about the expectation that safety net organizations will settle for old or used medical equipment, right? So they talked about funders who kind of encouraged that and the problem with that in terms of the implication that people using the safety net don't deserve the top-notch, high-quality health care. A frequent recommendation was to provide more general operating grants. It's probably unsurprising to folks in this room, right? That those dollars help support organizations' ability to just do the work that needs to get done. In terms of next steps, these are our initial themes, so we'll be continuing to fine-tune them, try and find more nuance within the data. I don't know how many of you have done qualitative data, but you could dig in for many, many hours, finding new kind of themes and new trends of thought across the data. So it's fun and fulfilling, but it's a lot of work. And as you can see, like you could kind of state these themes in a number of different ways and break them down. So I hope the story and the thread has come together in a decent way today. And there's more detail again in that 4-pager that you have in your packets. So we'll sort through those issues raised in policy recommendations from interviewees and be making kind of our own recommendations, adding our own analysis to that as well. Then we'll finish writing, editing, and publish, and we'll be sure to send that out to all of you since you registered for today. Again, I want to thank Margie Schaps, who's a thought partner on this, our executive director, Sharon Post, who's also been a great thought partner on this and done a lot of the work with me. And then the Washington Square Health Foundation for their support for this research and again for today's forum. So with that, I think I'm going to take, what time is it? 37. Okay. I think we're doing okay. I'm wondering if Luvia, if you would want to come up. Did I see you come in? No?
She's here.
Oh, she is here. Hi. I thought I saw you. Thanks for being here. Do you want to I mentioned it briefly, but yeah.
Hi, good morning, everyone. As Wesley said, my name is Luvia Quiñones, and I'm the Health Policy Director with the Illinois Coalition for Immigrant Refugee Rights. So just wanted to make sure, I know Wesley referenced our more recent fact sheet. We as ICE are one out of many organizations trying to fight back around public charge. So we just wanted to, make sure that you had this fact sheet. We do have this fact sheet in a couple of different languages. And most importantly, we also wanted to just make sure everyone knows that we are happy to either put together presentations, trainings, webinars, etc., because our goal is to make sure that people have the most accurate information. I don't want to take too much time, but just to make sure that everyone knows, the public charge rule did not go into effect thanks to a couple of different lawsuits, including the one that we led with the Shriver Center Legal Counsel for Health Justice. We were able to put a temporary hold, but unfortunately it's not definite. So we still need to make sure that not only are we working all together, but that we're also informing our community. Thank you.
Well, next, we're going to start with our panels. So I'm going to invite Graciela Guzman out to introduce our very first panel. Thank you.
Hello, good morning. I think I have to do a little bit better than that. I know it's like 9:37, the first cup of coffee, but I need you to be like 2 cups of coffee into this. So good morning. Good morning. I'm Graciela Guzman. I'm campaign director at Healthy Illinois, and really excited and happy to be here moderating these 3 panels that'll be taking place. So the first panel that I'm happy to call up is our state government perspective. So I'm happy to call up Ramon Gardenhire and Corey Ann. And I'm so sorry, would you mind pronouncing your last name for me? Thank you. I'm really sensitive to last names being mispronounced, but why don't I have you come on up and then I'll introduce them. Thank you. Thank you so much. Is it okay, actually, can I just join them on the table? Thanks. My style, a little more formal. All right, good morning. So happy to have here Ramon as Deputy Chief of Staff of Policy for the Illinois Governor's Office, and Corey Ann, who's Special Assistant to the Secretary for the Illinois Department of Human Services. So as the first question, that I'd actually like to pose to both of you, given some of the findings and key findings of this study and report, our communities obviously has a very vested interest in where the progress is on Medicaid redetermination. So I'd just like to open it up with an opportunity to be able to comment on how the implementation of SB 1321, the Medicaid Omnibus, is going, and in particular if there's any findings that you may have in terms of initial numbers, workflow, any progress that's been done towards the Medicaid redetermination problem.
Hi, as she said, my name is Corey Ann Galkovich. I know the last name is a little difficult to pronounce, but that's all right. So I wanted to give a little bit of background because I know everyone has heard the words Integrated Eligibility System, or IES, and they get very frustrated with the new system that we put in. So if you don't mind, I'm going to just back up a little bit. So what you may not know is that we put in that new database, and that has been going in over the last couple of years. And I know it's caused a lot of frustration, both for us and for everyone else. But the last time we had a new database was the 1960s. So basically, we had a database at a time where rotary phones were like the thing, okay? And then we tried to jump to the iPhone. Can you imagine jumping from rotary phone to the iPhone? We skipped landlines, we skipped flip phones, we skipped all of those steps, and we had to do all of those steps because that infrastructure has to be there in a very short time period. So that's what we've been doing the last few years. We jumped from a rotary phone to an iPhone. So we're very excited to have the iPhone, but as you can imagine, that kind of jump is not easy. So that is sort of where we got a little bit behind and where we got the backlog. As we rolled out IES, and we had this great, iPhone, but we had people who were used to the rotary phone, and they knew how to dial that rotary phone without looking. And all of a sudden we handed them an iPhone, and we're like, that's gonna take some adjustment there. At the same time, you had the Affordable Care Act, which was absolutely fantastic, but roll out and add a lot more people there. So we got a backlog. As you can imagine, it's something that we've been working through, and I have a lot of people say, this rolled out in 2017, how can you still have a backlog 2 years later? Well, good news is, some of you in the room will know, it's a lot better than it was. It's nowhere near where we want it to be, where anyone wants it to be. But a backlog is sort of like a traffic jam. Have you guys ever been in a traffic jam and you're driving and you have no idea why all these cars are stopped? They're stopped because 3 hours earlier there was an accident. But because that accident didn't, that accident cleared up, but the traffic jam is still there because you still have all those cars coming. That traffic jam gets cleared up in the middle of the night where there's less traffic. We don't have a less traffic time period. Those applications, those redeterminations, they come regardless. So we've never had that middle of the night where we can catch up. We've had to do it slowly a little bit at a time. So I just wanted to sort of give that background of where we're at and what we're working on. We've made tremendous progress on our integrated eligibility system in the last few years. We still have quite a bit to go, some enhancements to make, some defects to fix, but we're getting to a good spot with that. And so in the last few months, we've actually reduced the application backlog by 37%, which is really great. And we see that continuing. We've got some great things that we've been doing. So some of the things we've been doing about the application backlog and the redetermination is a lot of like system improvement. And I know that sounds like, oh, what are you doing? It's a lot of back-end improvement. So as you can imagine, when we went to the iPhone, you can't have the same process that you work on when you had the rotary phone. So we had to change a lot of our business processes. So that's something for people to get used to. We've had to hire a lot more people, as you've noticed in the last couple of months. We've worked with our sister agencies to sort of streamline how we hire. And we have hired net new, so that means more people have come in than we've lost, because like everything else, as you guys were talking about some of the slides earlier, some of the things that your staff faces, staff turnover, staff burnout, that's obviously something we face as well. We've hired over 200, I don't have the numbers, probably 250 net new caseworkers over the last few months. Obviously they have to be trained because, as you know, some of these, SNAP and Medicaid policy are not easy things to know. So once they get trained up and out in the field, they will help things tremendously. The other thing that we have done is, the good thing about an integrated eligibility system is that on the back end, a lot more is because it's automated, it can be shared. It's no longer the paper that we had before. And yes, with the rotary phone came big stacks of paper. That's what we are working on. So instead, what we can do is now, any work that's there is, we're gonna set up statewide processing centers. So those are gonna be centers where we're gonna staff it with caseworkers, but these caseworkers are gonna be working on, I'll consider the back end. So all those things that need to be done in the background in order to get somebody services, they're gonna be working on that. So the people who have customers coming in the door, so if you've got an office lobby that comes in and they look around and go, whew, we're pretty full this morning, what they can do is they can flip that switch and say, hey, statewide processing center, can you take our back end work for the day? Because we don't want to fall behind on that, because if you fall behind on that, then you fall behind on everything. But we need to see our customers. So what they're going to be able to do is focus on the customers, get the information from them, and make sure that we see the customers, whereas we're not falling behind on that back end, so we're still timely with our applications, our redeterminations, and doing that. So we'll be rolling those out starting in January and then over the next couple of months. We're also going to be putting in a new call center that is going to be coming out in the spring as well, and that is going to be able to take redeterminations of, I told you I'd circle back around. So redeterminations over the phone, so to make sure that we can get to all of those for people. So there are quite a few things that we are putting in, and we know the frustration, because it's our frustration too, as I've often talked to many of you in the crowd. We've been across the table from each other, but we're sort of unique in the fact that we're across the table, but we're not really across the table, because your customers are our customers. We want to serve people just as much as you guys want to serve people. So those are some of the things that we have worked on. Did I answer some of your question, or?
You did. Ramon, is there anything you'd like to
Yeah,
add?
I'll piggyback. I think Korean did a great job of giving specifics of kind of what the agencies are really doing to help eliminate the Medicaid application backlog. I want to make sure that everybody knows that this is a major priority for the governor. At his direction, 3 agencies, DHS, HFS, and DO-IT, are working in tandem to really ensure that we are helping to completely eliminate the backlog as we move forward. Expanding access and continuity of care is a major priority for the governor. I think 2 other components of the Senate Bill 1321 that I also wanted to briefly touch on. One of the components of the law mandated that HFS start to looking at adding new populations around ex parte renewal process. And so the agency HFS is doing some research right now. The report will come out soon, but hopefully we'll be able to shed some light on potentially some new populations that we would be adding to that process. And then also too, one of the things that HFS is currently in the process of doing is hiring an external vendor or a monitor to help us really assess how we can improve IES and make it work better and more efficient. And so they're in the procurement process currently of that, and an announcement about a vendor will likely be made as soon as maybe this week or as early as next week. So we are charging full steam ahead to ensure that we are really making sure that we eliminate these backlogs.
Thank you. Ramon, just looking forward, tomorrow is November 1st, right? And it marks the beginning of open enrollment into the health insurance marketplace. So just wanted to be able to ask, how is Illinois helping prepare for this next open enrollment season, given so much of the federal sabotage and the cuts in marketing that have taken place, not just at the state level, but at the federal level, that are really impacting how folks hear about open enrollment?
Yeah, so our Get Covered division of the Department of Insurance has been actively working to be able to roll out ads. So you'll see some very targeted ads in certain populations, which we have seen have not really utilized healthcare coverage, which have also been eligible for it. So those ads will be rolling out as soon as today, actually. And those will be a combination of both print, paid media, some earned media as well too. We really want to make sure that we're using the bully pulpit of the governor's office to really ensure and encourage people to enroll into healthcare coverage. Graciela, as you mentioned, unfortunately there is the specter of kind of the federal government and their efforts, everything from slashing, open enrollment periods to the Republicans' efforts to try to repeal the ACA. We continue to push back on those narratives because what we don't want to happen is a fog of confusion that happens out in the public that, you're hearing from the federal government that the ACA is unworkable, that it's not meeting people's needs, and we all in this room know that's not the case. And so we'll continue to use the bully pulpit of the governor's office and of state agencies to ensure that we are educating and helping to enroll as many people as we possibly can in this open enrollment period.
Thank you. Corey, and thank you so much for your remarks just on the systems improvements that the agency is making. And you mentioned the state processing centers as a way that each individual office will be able to start making notable shifts in workflow that will allow them to be able to service customers in a more meaningful way. Some of the findings that we've found from the report, but also just from anecdotal conversations, also refer to some of cultural aspects, things that happen in actual offices in terms of ways that folks feel undignified or that their humanity isn't being upheld by actual staff at centers. And I'm just curious if there's been any efforts around that level of training or staffing accommodation that really would allow for customer service to be done in a more dignified way for consumers.
Yes, customer service is a big thing for our secretary. She came in and that is one of her biggest things at the behest of the governor is customer service and kindness and treating people, the way that they should be treated and the way you would want to be treated. So one of the things that we did this summer was some lobby reforms. So as you know, sometimes we have long wait lines in the lobbies. So we have reworked that so that we have somebody who is there out front, one of our managers or a caseworker, who can treat people when they come in and triage them. So, if you're just dropping off papers, you don't have to wait in a long line to drop off papers. If you're there for one of your interviews, you go to a certain line, and really making sure that our lobbies are being used effectively and that the caseworkers then can see people that come in. We also had a lot of manager and caseworker training this summer, and a lot of the focus was on customer service. But again, sort of like your slides were saying that, you get burnout in the medical field, you've got to realize our caseworkers, most of them, they're there because they want to help people. And they're just as frustrated when they feel like they have to rush through because we have to get these things done, we have to get that moving. And that's why I want the statewide processing centers to be able, so they don't have in the back of their head all that background stuff that has to be done, that they can focus on that so they can focus on the customer in front of them. So those are some of the things, but yes, definitely a focus on customer service and making sure that we're treating the customer as they should be treated, and we're making sure that we're serving them when they come in.
And I'll just add that from both Secretary Ho and Director Eagleson have made this a primary focus of their efforts in terms of kind of reshaping our healthcare delivery system to make sure that we have an equity-centered approach to ensure that everybody is treated properly and with respect, because we know that those kind of systematic things impede people's ability to actually stay enrolled into healthcare services, and we want to make sure that we are eliminating those barriers and treating people with the humanity and respect that they are due.
Thank you. So I think I'd like to ask each of you just one more question, and then we'll open it up for questions from the broader community for each of you before we move on to the next panel. So Ramon, Governor Pritzker campaigned on a public option as a way to be able to start working towards Illinois' affordability and coverage access problems. So how is the governor's office looking to plan for and develop its public option? Do you have any updates or plans that you'd like to share with us?
Sure, I'll say as much as I can. So the governor has convened an interagency working group, which consists of all the major agencies which touch healthcare services, so HFS, DPH, Department of Insurance, et cetera. And we are early in the infancy stages of kind of looking at some reimagining healthcare delivery systems. Everything is on the table to look at. We hopefully will be able to make our recommendations to the governor relatively soon, and then from there, I think that we look forward to working in tandem both with members of the General Assembly, but also people in this room to really help shape how we can really reimagine, and to use a term that the governor often likes to use, is think big about our healthcare delivery system and how we can both make sure that we have both affordability, but increase access to healthcare coverage for all of Illinois residents.
Thank you. I think this question could go to both of you. If you could speak for ways that the governor's office or your agencies are working to combat against efforts from the federal government. And there's been many, right, in the last handful of months, attacks against the Affordable Care Act. Luvia mentioned public charge. If you could just speak to any notable efforts where the governor's office or your agency is presently working to protect Illinoisans and their access to healthcare access.
Yeah. So I think that, one of the things that the governor, working in tandem with the Attorney General's office, is very intentional about is making sure that we join multi-state lawsuits to push back on efforts to repeal the Affordable Care Act or reproductive health care as well too. Unfortunately, the attacks come fast and furious, at both the large P programmatic level, but also at the small P policy level as well too, whether it's through, rules changes, but all those things we are vigilant in pushing back. The governor has been extremely forceful in pushing back on the Trump administration when they have tried to put in kind of these draconian efforts to kind of claw back healthcare services that people are rightfully owed, and we will continue to do so in the face of opposition and tyranny by the Trump administration sometimes as it relates to healthcare services. But I also too want to really encourage all of you who continue to do this work every day. It's important that you also stand up and push back on these efforts, because of what the Trump administration is trying to do is create a fog of confusion and disinformation. And the more that you guys are trusted ambassadors in the communities that you work with can really go out and push back on these narratives, false narratives oftentimes, it's important. And the governor's office is a willing and able partner to work with you to make sure that we can partner with you to help get accurate, correct information out to communities about healthcare services.
Thank you. I'd love to open it up to folks out there. If you have any questions, we will give a second for Wesley to be able to get that mic up.
Also, if you're standing in the back and you'd like a seat, there's a handful over here. Feel free to come on over. Any questions from the audience for our panelists?
Would you be able to tell us where you're at in terms of the elderly simplified application process for redetermination under Medicaid? ESAP?
Yeah, that's aging, and I'm not quite sure, but I can circle back to Graciela and to Wesley and make sure that we get you.
We strongly encourage you to take a look at that. It's particularly difficult for homebound people to go through the redetermination process when many of them have not had their status changed hardly at all. Thank you.
Thank you.
Other questions for our panelists? Yes.
Hi, I just had a follow-up question about the Medicaid buy-in public option process. In looking at other states that have gone down that road, who might be a little further along than Illinois, they typically pass some sort of task force or study or commission through the legislature, like an officially deemed body to look at this. Is that the direction that Illinois is heading in, or is it going to be more of an informal stakeholder process and then going straight for trying to implement a program?
So being as transparent as I can, our options are on the table. And then I think you're mentioning like feasibility studies. I know a couple of states have done those, like New Mexico, where they partner with the General Assembly to have some appropriations to be able to do an exhaustive review of like if the state wants to move forward on a public option, Medicaid buy-in, et cetera, how to do that. I think that all options are on the table, and I think that hopefully we'll be able to announce something soon. As I said before, we look forward to working in tandem with members of the General Assembly and with folks in this room to ensure that whatever we come up with works for Illinois residents.
Thanks.
Hi, I can't see, so I'm gonna have to stand up. My question relates to the buy-in as well, and it's really coming from the mental health and substance use side of things. I think a buy-in obviously would be great, but there's a lot of details that need to be worked out. But I hope that the administration will also, in figuring out whether or not or how to structure a buy-in, is really how to grow access, because the mental health sector, there's really very, very, very limited access through Medicaid. And actually, I think we are going back the other way because we're in full employment and we're really, really having to compete with managed care companies and other healthcare providers in terms of workforce. So I think a lot of providers are actually shrinking at the moment. So just figuring out what the long-term strategy is for building access to care in addition to coverage. Is that something that is being discussed at all?
It is. Access is one of the paramount issues on the table, in addition to affordability. So, Heather, to your point, yes, it is a salient point that we continue to look at, and hopefully, again, we'll be able to announce more details as we move forward. Sorry, I can't be more prescriptive, but we're still in the working infancy stages of kind of figuring out what the it is going to be.
I have one question up in the front, headed your way.
Hi, thank you to the panelists. I'm Dr. Angel Miles from Access Live. I've lived and met you before, Corey Ann, and I just wanted to reiterate the importance of making sure that all aspects of the system are accessible to people with disabilities, and making sure that whatever centers you have are also accessible. So oftentimes those spaces, they're not places, for example, for wheelchair users to sit, and things like that. So making sure, and also making sure that the websites are ADA compliant, and that people know that if they, for some reason, that there's a health reason that they can't come into a center, that they know that they have other accommodation options, because often they're told that if you can't come in, then you can't be served, and that's not true. So most people don't know that. So if there could be even like a part of the website that has something about accessibility, your rights to accessibility accommodations would be really great. So I just wanted to put that out there, because disabled people have a lot of health disparities. Thanks.
Yeah, thank you. Angel, as you know, because we have spoken before on this topic, is that Illinois actually has the Illinois Information Technology Accessibility Act, IITAA, and it actually is a little bit more advanced than the ADA, and that's actually driven by DHS. So our CIO is actually the one, he came up through the system, he came through doors, so that's something that he focuses on incredibly, because he was very involved in that and rolling out the rules for that as well. So yes, that's definitely something, that's the technology aspect of accessibility, and we're always working with state CMS and our landlords to make sure that things are accessible for our customers as well. But to your point, yes, obviously you can have access there, and then the call center that we're setting up, we do know it's a little difficult to get a hold of us sometimes right now. So one thing that I did forget to mention, so thank you for bringing that up, because I mentioned the new call center that we're going to be going on, so that'll help with retermination, so people can call rather than coming into our offices. But also we have a grant we just got from FNS, this is Food and Nutrition Service, and that is to work on our technology for our calls. So don't want to bore you with the details, but sometimes the phone just rings just because it's not connecting into our office. So we do have a grant there to help with our phone systems to make sure that our phones are answered by everyone, and then it's also going to help set up this new call center, which is, it's going to be at least 50 new people who are just going to be answering calls. So that will help as well. But no, definitely we fully abide by the IITAA. I know, yet another acronym for everyone to know. And yeah, we set out the rules for that, and we're very cognizant of making sure that everything is available and accessible.
Hi, I have like two-part question. So you mentioned that it's going to be a call center for redetermination. Are you going to be staffed by bilingual staff? If so, how many different languages? Or if you're going to be relying on translation services? And I just want to point out that because a lot of the application and redetermination or renewal really depend, and a lot of people depend on their CPO because of the language barriers. So I want to see if you will have multilingual staff there.
Yeah, that's definitely something that we take a look at. We try to make sure that our offices do reflect the communities that they live in and have those languages. But in case we can't get enough people with the various languages, we do have a contract with the language line, so it translates to over 200 languages. So when somebody comes into our local office and they do speak a language that a caseworker doesn't speak, they can do that. I actually have personally analyzed the data from the language line, and we're taking a look at the top 10 languages we've used, how often we've used them, to sort of try and staff up in the areas. But yes, that's obviously something we would rather have the person who speaks the language. That's our top priority, but then we do have the language line as backup for that as well.
Looks like we have one in the back. Maybe this is our last
This is
one.
the last question, I think.
Okay, first of all, thank you, and just also like a two-part question. I know you talked about like kind of trying to make the redetermination process more efficient as far as processing it on your end when they come in. The clients I work with are consistently getting their redetermination notices after their redetermination date. I don't know if you're doing anything on that end. I'm wondering if there's anything going on there. Also, as far as like the Connect and T cards, is there anything going on there as far as getting that? Because that's another thing. Applying for those aren't getting done in a timely manner. So I don't know if there's anything to do to make that more efficient. And then also, you had mentioned trying to make like your offices and everything, trying to make them overcome, break down barriers and to make make them more accessible and stuff. And I'm not trying to be antagonistic, so if it comes off as so, I apologize. But the only thing you mentioned was just to kind of be more customer service friendly. But I deal with a lot of clients that have already been let down by the systems, and to the point where they are actually deciding to not take their insurance, to just be done with Medicaid and not deal with it anymore. And I have to do everything I can to convince them to stay on Medicaid. So like what specifically are you doing other than like customer service and like kind of like friendlier faces and to break down those barriers and all the red tape that these people have to go through just to do something as simple as a redetermination?
It was a three-part question. I just want to make sure we recap it. So you listed the example of like specifically redetermination, like delayed redetermination, like packets coming in.
I'm sorry, the mail.
The mail, and then T cards.
I remember that. Okay.
Yeah, and then customer service beyond just friendly faces.
Okay. Yeah. Sorry, I forgot the first. Yes, so the mail. So obviously when I was talking about the integrated eligibility system, there's a lot more to it. There's data cap, which is scanning, there's the mail room. So yes, we are actually in the process now of setting up a second mail room. So this is a lot of back end stuff, but that you guys will see the benefit of in the front end. So a second mail center so that we do have those coming through, because as you can imagine, anything else, we get a lot of mail in. So making sure it gets scanned, and then our mailroom, can get things out. It's sort of like the mailroom is cyclical, like anything else. USPS gets backed up at tax time. We get backed up at midpoint reports. So making sure that we have enough equipment and we're trying to move to different shifts so that we can make sure to stay on top of the mail. We did have some issues, so you're probably saying, I'm hoping that is not the case right now. Things do change very fast because we are making a lot of improvements. So yes, about 8 months ago, we were having some trouble getting the mail out on time, but we have streamlined those. We put in some new equipment, some new stuff, so the mail should be coming a lot better now. Again, if it's not, let me know, but okay. So there's that. So then the Cohen notices, yes, obviously, for those of you who don't know, I know people in the room can give you lots of information on the Cohen notices. Yes, Stephanie, I'm looking at you. But basically, yes, if we are behind as the state in getting applications out, people can get temporary cards, and we definitely want to make sure that is out there. We have notices that go out to people and tell them the variety of methods that they can ask for their temporary card while they wait for their full Medicaid to get determined. There is a phone number. I don't have it memorized. I'm very sorry about that, but we do have some dedicated staff at our phone line that Impasse runs that is just doing temporary cards. So you press a certain number, and actually Stephanie can probably tell you what that number is. You push a button and then you'll get right to somebody who will help you with the temporary card. You can also send that request in, obviously, through MMC at the local offices, and that's some of the triage we were talking about when somebody walks in and says, like, hey, I just want to apply for the temporary card. They can do that quickly rather than waiting in the full line if they need to do the interview. So yes, we have been successful in the last few months of increasing the amount of temporary cards that we are getting out for people who we are behind on the applications, and we are always trying to increase that as well, because we really want to make sure that people have the coverage, even if we're a little bit behind, that doesn't stop people from getting the coverage that they deserve. So yes, that is a real thing. We do send out the notices to everyone, but if they're not receiving it, they can always call us. Even if you don't receive the notice, if we are behind, they can call after that day and say, yes, please do that, or go through MMC or come to the office and ask for those cards. And so we are issuing many more. I think a year and a half ago, we were issuing very few, and now it's in the thousands of issuing those. So we definitely want to make sure people get those temporary cards that they are eligible for. And for the last one, those are what you were saying were stories that we just get devastated by that, because we want people to get the services that they deserve and that they need and that we can give them. And so we really do hate hearing the stories that people have just given up on us. And we really dislike that. So we really do want to encourage people to come back. We're doing all of these things so that we can serve people and they can get the services that they deserve and need.
And I would just, and to your point, we don't view your questions as being antagonistic. We understand that there are deficiencies in the system. But we also recognize that, like any kind of systematic change, it doesn't happen overnight, that we're changing the course of the ship. But we encourage you guys to work with us and to also point out where we can be better. And so we welcome these kind of dialogues with stakeholders to let us know where the holes are in the system that we really need to plug in. And so we continue to want you guys to interface with us, let us know how we can improve the system, because at the end of the day, that is what it's about. It's ensuring that every Illinois resident which has access to healthcare coverage, and not just healthcare coverage, but high quality, comprehensive healthcare coverage. And so please continue to point out those deficits.
Thank you. Please join me in thanking Ramon and Corey Ann for participating in this panel. Thank you so much. And we'll just take a quick second to get set up with the second panel. We're just getting this panel started. Here we go. Sorry, that's just the camp person in me does that. So as Wesley mentioned, we had originally had an insurer perspective on this panel that was unable to be here this morning. So the panel primarily will focus on a wide set of diverse system delivery perspectives from the providers that I'm about to introduce. So I'm happy to be able to introduce Jay Shannon, CEO of Cook County Health, Stephanie Cox-Baxton, Chief Medical Officer for Near North Health Center, and Heather O'Donnell, Senior Vice President of Public Policy and Advocacy at Thresholds. So I think with that, the first question that I wanted to offer up, just as a point of commonality, I think between Dr. Jay Shannon and Dr. Cox-Baxton, just the findings around work flow and workforce, in particular things like burnouts, challenges with recruitment, underrepresentation. I'm wondering if both of you would mind speaking to the ways that your systems are working on addressing these kinds of issues within your workplaces.
Hi. Well, I'll start with us since we're sort of the microcosm of the larger Cook County system. I think the first thing I'll talk about is addressing provider burnout. I think we're all familiar with the triple aim, but a lot of times now we're talking about the quadruple aim, with that fourth arm being provider satisfaction in their job place. Burnout is at an all-time high. The suicide rate amongst physicians is also at an all-time high. And we find many people are leaving the profession, not because of lack of pay, but because of dissatisfaction. That's actually one of my sort of personal areas of interest, and in our provider staff, we have about 50-some providers. We've really been focused on retention and addressing the things that lead to burnout. What we have found at our organization in doing internal studies, which is very consistent with what we see nationally, is that one of the things that contributes significantly to provider burnout is the electronic medical record system. My theory is that this might correct itself in about 15 or 20 years, but right now, the workforce we're dealing with is a large workforce of physicians that went into medicine to interact with their patients in a different way than we're currently required to do. So this is creating a lot of stress as providers no longer get to have the same face-to-face interactions that they used to deal with. And as you can imagine, finding yourself clicking several times to send in a prescription where you used to be able to scribble it. Now, granted, maybe no one could read it, but it was fast. So there is that. We also, in our organization, have been looking at ways to make providers feel appreciated. So one of the things that we have done was we actually sent out a survey to look at what makes you feel appreciated in the workplace. With the theory being that it's different for every person. Some people want a shout out in public, some people don't. Some people just want a pat on the back in private, or could you give me an extra 30 minutes for lunch? The other thing we find contributing to burnout, again nationally, not so much with our organization in particular, is the amount of time providers are spending outside of office completing paperwork and catching up on electronic medical records. And that average is about 2.5 hours an evening for providers, with longer time on the weekends. So all of this is contributing to burnout. When you are in the world that we are in, which is in the safety net organization, our salaries don't always compete with those in the private sector, and you layer on these other factors, and that makes it very difficult to recruit and retain staff. So the mission gets them in the door, but the mission doesn't keep them there. And that's what we are sort of struggling with.
Good morning, everybody. Yeah, I think Dr. Cock-Batson's points are all equally applicable in the county health system. I guess I'd add a couple of pieces. You know, there's no question that people enjoy their work more when there are more resources around. And just as with the FQHCs in the county health system, we're not a resource-rich environment. You're not going to find anybody playing the piano in the lobby when you walk through. And oftentimes people are having to do things in a way to save dollars where it puts an extra burden on them. And I think a lot of the same experiences of trying to jam requirements of work into an already tight work day oftentimes means cutting out your own personal time and your own breathing time. I think the second big challenge, and I'd certainly echo everything that was said about the electronic health record, but the other challenge that most people find as a common one that leads to workforce burnout is a lack of agency. And one of the biggest challenges that we have in that regard is that out of our 6,500 employees, 90% of them belong to one or another bargaining unit, And unfortunately, the bargaining units have been very effective at getting them good salaries and benefits. What they haven't been good about is allowing a flexibility and agility that allows a person to develop within our healthcare system professionally. So people come in, they join one of 25 different bargaining units, and they accrue seniority as employees of the county, but they are also accruing seniority with that bargaining unit. And if they leave that bargaining unit because another job that might be of interest to them is in a different bargaining unit, they lose their seniority and they put themselves at some risk in that regard. And so that limits the freedom that people have to professionally develop and to professionally grow. And I think another challenge related to that is that our job descriptions tend to be rigid and limiting. And so people will feel like, you know, I can do these things, but I can't do this one thing that's outside that box, either because I'm not going to do it, or if I do it, I might get challenged by somebody else whose box that falls into. And that tends to also inhibit creativity and independence and agility in the workplace. I think those are challenges. Now, we don't have the same manifestation of people leaving us. In fact, quite the opposite. The most common reason people leave us is because they retire. The golden handcuffs that were associated with the benefits of a county job that were present in the 80s and the 90s are gone. And so that has changed. Now I think our salaries are good. I think the benefits are good. The vision of clocking in and then 33 1/3 years later clocking out with a very good defined benefit program is kind of fading in the distance. And so that's an ongoing challenge for us of how we're going to attract and retain people going forward.
I know this question wasn't directed at me, but I think that we have similar problems, but a little bit different. So Thresholds is a community mental health agency that serves people with severe mental health conditions. We employ about 1,200 people. Most of them are social workers, outreach workers, some therapists, psychiatrists, and other professionals. But I think one of the biggest challenges for people on the front lines is that and most of our services are provided out in the community. So in somebody's home, on the street, or wherever somebody is most comfortable receiving services. We do have clinic-based services, but probably 80% of our services are provided outside of an office setting. It's very difficult because you have to go into neighborhoods, oftentimes that are unsafe. You have people experiencing mental health crises, so it's very difficult work. And I think what causes a lot of burnout, we are not able to pay people what they are worth because about 96% of our services are Medicaid covered. And so we're just limited based on rates. But I think maybe a larger issue for our staff is a regulatory structure that doesn't allow for creativity or innovation. And I think it's a lot different than what therapists or social workers thought they would be allowed to do. They don't have the ability to do within the Medicaid regulations. We actually literally cannot do things like integrated care between mental health, substance use, and physical medical care because the regulations don't permit it. We can't sometimes go sit with a client in a doctor's visit, maybe who's experiencing a mental health crisis and may not be able to sit there alone by themselves while they're waiting to see a practitioner. And so I think burnout is related to sort of the reality of the regulatory constraints that have been placed on them that were developed many, many years ago and decades ago, quite frankly, that just don't reflect where we're trying to go as a society with healthcare reform, the Affordable Care Act, more integrated care. And I think until we address some of these things, it's hard to address the burnout because providers are simply limited in how we can deal with it.
Sure. Thank you for that. Shifting gears just a little bit, something we haven't been able to chat in either panel yet about is the Medicaid managed care. So just wondering, thinking about the vantage point of your 3 institutions, what promise do you see for Medicaid managed care, and what do you think needs to happen in order to make that promise a reality?
Well, I can take a crack at that. I think just as a quick matter of background and context for everybody, I think you're aware that Cook County Health operates County Care, which today is the largest Medicaid managed care organization in Cook County. It only operates in the county. 4 of the Medicaid plans are statewide. So today we have 320,000 members in the plan. That plan has a broad network that includes our health system and our providers, but it also includes another 50 hospitals in the county, some 20,000 physicians and so on. So it's a very, very broad network. The impact that county care has had on the county health system can't be overstated. It's done a number of things kind of from a cultural standpoint and an important strategic standpoint. The first is that many of the people that we took care of for years who were uninsured now have coverage under Medicaid. So for the first time in our history, we are caring for a majority insured population. Now it's just a bit, it's 55% of the population that we're taking care of that are insured, but that's a sea change for us because we've historically taken care of an uninsured population. It has brought significant dollars into the system. $1 billion over the last 5 years have accrued to Cook County Health because of the services that we're providing to county care members within the healthcare system. That has allowed a marked reduction in local taxpayer dollars going to the health system, and that fosters a totally separate problem that we may end up talking about, and that is charity care, which has outpaced our ability to pay for it today. But the other thing that county care has allowed the health system to do is to greatly expand the number of individuals that we touch. It's probably tripled the number of county residents that the health system is able to directly impact, and that scale also gives us a platform to innovate. And I just give you 2 quick examples of where we've been able to innovate because of the fact that we're operating that plan. Actually 3, and I'm not going to go into detail about these unless we have time. One is care management and care coordination. It's brought dollars in that's allowed us to do things, if you will, outside of the clinical moment that we wouldn't have been able to do before. The second is around behavioral health, and we've had a 5-year strategy to improve behavioral health services, not just within Cook County Health, but across the entirety of the county. And the third is around substance use disorders. And all 3 of these have had a focus on the populations that we've historically cared for, which are vulnerable, oftentimes ignored populations, homeless, people with behavioral health problems, and justice-involved populations.
Thank you.
I think that one of the promises that we see in managed care is the ability to move away from fee-for-service Medicaid. Fee-for-service Medicaid doesn't work, in our opinion, does not work for Medicaid enrollees. It does not work for providers trying to get the best health outcomes for their clients. Fee-for-service really drives providers to hit volume targets. I know that's not what a lot of people want to hear, but providers have to survive. So you have to provide enough of the services to be able to pay for the care that you're delivering. So there's a lot of perverse incentives in fee-for-service. So I think what we see as an opportunity under managed care that has still not been realized, but we remain hopeful with some other changes, is value-based payment or outcomes-based payment arrangements with managed care companies that give providers the freedom to provide what Medicaid enrollees need to get well, to manage their mental health condition, to move into recovery, to deal with their medical symptoms. So you hit good outcomes and you get you can get potential bonus payments or a higher case rate, but you're basically paying for value. The challenge is that the entire Medicaid system underneath managed care is fee-for-service. And until the federal government realizes this and until the state realizes this and adjustments are made, I think we're just gonna have little pockets of payment arrangements driven toward value. So my hope is that in addition to talking about the big things like a Medicaid buy-in and adding different services to Medicaid and things like that, that we actually sort of roll up our sleeves and get into the nitty-gritty of the regulatory issues around Medicaid, because I don't think we will get there. I don't think we will realize the promise of managed care until we deal with that. And then one thing I do want to talk about with respect to challenges of managed care is that Illinois, just historically, we all know, has not really funded Medicaid to the extent that we need to. And we take on huge systemic changes. And because the state has very few resources, the state has literally spent no time building up, helping providers invest in the infrastructure they need to actually really operate in a managed care environment with the technology we need, the data tracking systems that we need, and for small providers, just the staffing infrastructure that is needed to learn how to even talk to managed care, how to bill multiple managed care companies when you only billed the state before. Mm-hmm. So there's just a lot that we haven't done that I think we need to do to make it actually really work well.
That was fantastic. She said almost everything that I was thinking of. So, I would say that the promise of managed care, I think the promise was, again, it goes back to the ACA and the triple aim. I think we were supposed to, have a better patient experience. We were supposed to address population health issues and all of this at a reduced cost. So I think that's the promise of it. I could probably talk longer about the challenges than I can about the promise. I'd say that one of the problems with our promise is that we left out sort of the individual experience, and I think with managed care, it is driving us towards value-based payments, which I agree is a really excellent thing to move away from this volume production that is, again, contributing to our burnout, having to see people every 15 minutes. However, we've got a new stressor as we now move towards value-based payments. And that is, number one, taking care of a safety net population. We have to figure out some way to create a system that basically issues some sort of rating scale on the population that you are serving in order to help address the value-based payments. A simple example is, we are paid bonus dollars for how many patients we have with hypertension that we can get into a normal blood pressure range. Might be easier for certain populations to do that than other populations. We have some genetic factors involved that I think we are very cognizant of, but that is not reflected in these value-based payments. Another stressor for us organizations is that we do have to have a whole nother stream of staffing that we did not have to have before. We have a big steep learning curve in trying to figure out how to bill for these various MCOs. And we have far too many of them with too many different criterion. So, one person cannot be very expert in all 8 of the plans. So now we've got to hire staff. And where's that money coming from? It's taking away from our patient experience. So There's a lot of opportunity there, but I agree completely that we're going to have some support from the state and helping us put the things in place to help us track things and track our outcomes and to help us learn how to bill appropriately.
If I can just add one point that Dr. Cox-Batson's comments remind me of. So I think many of the people in the room are aware of this, but I just want to, at a high level, give you a sense of the challenges in Illinois as it relates to this. We're dead last in spending per Medicaid beneficiary across the country. So the spend in Illinois is about $5,000 per Medicaid enrollee. The average, the last time I looked at it across the country, is about $7,500. And there are many states where the spend per enrollee is $10,000. Now, if you think about the fact that the average spend of national healthcare expenditures in general is about $10,000 a year for every man, woman, and child in the country, what it tells you is that fixed expenditure on the Medicaid population in Illinois has already reached the it's reached one part of the triple aim, the cost-saving part. Whether it's reached the quality and the experience part, I'll leave up to people, but this is a gigantic challenge. I sit on the board of the Illinois Hospital Association, and we've had a series of meetings about transformation of care in Illinois, focusing on hospitals and so on, and the observation is frequently made that there just isn't enough money in the system right now. And so the provider rates turn out to be bad for mental health providers. The reimbursements turn out to be bad for all kinds of providers in the Medicaid space. And as we've transitioned from fee-for-service to managed care, 5 out of the 6 Medicaid MCOs have a profit motive. And I'm not criticizing that, I'm just observing it, so that if you say, I'm going to give you this much money to manage this population of people that are in your plan, and by the way, you've got to make your organization's margin out of that. That money comes directly out of patient care. So it is a structural and fundamental problem that for probably the most vulnerable and challenged demographic population in the state, the least amount of dollars are there to support their care.
Thank you. Looking at our time, I think I'd like to ask each of you one question, and then we'll open it up for questions from the broader community. So Dr. Shannon, I think at the beginning when you were kind of giving the systems overview, you talked a little bit about working in an environment that isn't particularly resource rich. And so just taking a look at Cook County Hospital has, according to the County Office of the Inspector General, an unpaid bill backlog in the hundreds of millions of dollars. At the same time, we know that the legacy of the health system is a mission of delivering health services with dignity and respect, regardless of people's ability to pay. I'm wondering if you can discuss Cook County Health's dedication to its mission for providing for all, regardless of ability to pay, in light of some of these resource challenges.
Yeah, so the first thing I tell everybody is don't believe anything you read from the Inspector General until you read the responses to the Inspector General's reports. We, like everybody else, have had to do a pretty rapid pivot from a simpler world, and actually the simpler world pre-ACA, the overwhelming majority of people that we cared for didn't have insurance. So we never had to know how to document, how to code, and how to bill, because you weren't sending a bill anywhere. Why would you waste time, resources, and staff to do that? We've had to pivot pretty quickly. As it relates to the mission of the organization and charity care, I'm happy to share with anybody. You can, if you would like, you can take a look online. I give a talk Monday at the City Club of Chicago about the challenges that we have with charity care. In 2018, we provided 55% of all the charity care of the health systems in Cook County. There are some 60-odd hospitals in Cook County. That was more than $350 million of services at cost. And that same year, we got 0 local taxpayer dollars into our operating revenue, 0. So how do we pay for that? We pay for it really through 2 major mechanisms. The first is we get a couple of block grants, if you want to call them that come from the federal government, called BIPA and DISH. These are Medicaid dollars, but they're not tied to an individual Medicaid patient encounter that's billed and coded for. And the total amount of dollars that we get in that is $289 million a year. So when we spend $350 million on charity care, we have an immediate and very serious gap. So the other way that we underwrite or offset those expenses is by revenues that we get from caring for the 55% of people that we care for who do have insurance. So every other week at orientation, when I talk with the new staff, I stress to them that their salary and the tools that they use at work and the care that we give to people who are uninsured are not paid for by the local county taxpayer directly. They are paid for by the revenues that we get for caring for the insured. I stress to them then that I don't want them to look at the people that they're taking care of and treat them differently if they're insured or uninsured. But it is just as simple as math can be, that we have about $290 million a year to underwrite charity care. This year, we spent at a rate of more than $1 million a day on charity care. So as I shared with the group on Monday, at the current rate, we would run out of that funding for charity care by September. It'd leave us about 3 months that we didn't have funding. Are we going to turn people away? Of course not. But what will happen is we will develop queues, number one. We will run out of supplies, number two. And number three, the challenges of doing that are going to crowd out and make difficult the experience for a person who has choice. A person who has an insurance card can go anywhere, is going to say, this place is crowded, there's a really long wait. Why am I doing this? I'm going to go across the street to another place. And that starts a vicious spiral for us. So that's the conundrum that we have, and it's going to require us to either get policy changes that enhance coverage at a state or a federal level, or it's going to require another political solution at either the local or the state or the federal level that gets us those resources. We have zero leverage to tell other healthcare systems to do more. Zero. Now the state does and the feds do, but the county health system has none, other than moral suasion.
Thank you. Dr. Cox-Paxton, another area raised in this research was the focus on social determinants of health, housing, food, transportation, and jobs, for example. Can you share what you think needs to happen from a health safety net perspective to focus on progress on meeting people's unmet social needs?
Yeah, hi. It's really like the big hot thing now is social determinants of health. And I think really many of the safety network organizations realize this. What I see happening is a lot of partnerships taking place. So I know at our organization and several of the other organizations that we, other FQHCs that we work with, we're really partnering with people that already perform those services to figure out how we can enhance them. So there might be some strategic partnerships with a housing organization or strategic partnerships with an organization that works towards providing educational support for those. Most of us are not in the position financially to go out and start doing this on our own. Of course, we do have social service people working in all of our organizations to help people connect with things that might assist, but that's a very, it's a very tedious process to do that one by one. Again, we're trying to address this on a larger population basis, and for that reason, the partnerships, I think, is what's really going to serve us.
Thank you. And Heather, what is the level of, and given some of your answers in terms of just ways that potentially there could be better integration between behavioral health and primary care, I'm curious just to hear your sense on what is the level of unmet healthcare need just across the delivery system, and how does that relate to reimbursement rates for psychiatry in particular?
Well, I can talk a little bit about the unmet need for mental health care. About somewhere around 2.5 million people in Illinois have a mental health condition, but only about a third get treatment. We have over 25,000 people in the Department of Corrections that have a serious mental health condition. We have over 10,000 people in jails, county jails, who have a serious mental health condition. we have over 22,000 people in nursing homes who have a serious mental health condition. These conditions are treatable. They are treatable if people have access to treatment and access to affordable housing. You asked the other panelist about social determinants. We cannot solve the mental health crisis that we have in the state without also dealing with housing. One of the primary challenges with respect to correctional deflection, deflecting people with serious mental health conditions who are in a mental health crisis from the jail system, the prison system, or hospitals is housing. And we can do this. Other states have done it. We actually expect to have housing legislation this next session, which will be very challenging, but it's just something we have to tackle. I think when you mention housing to elected officials, their eyes sort of glaze over like, oh my God, how are we gonna do this? But it is doable, and we have to tackle that. So it's not just reimbursement rates. Oftentimes I feel like a broken record because I talk about the need for rate reform and regulatory reform all the time. What we really need in the state to tackle mental health and the opioid crisis is a vision. We have never had a vision for a long-term vision. We will not fix this in 1 year or even 4 years. It's probably 10 to 15 years to 20 years. We have to address the workforce challenges. We have to address reimbursement challenges. A lot of people have, more than half of Illinoisans have private insurance. And mental health conditions begin when people are mostly when people are adolescents and in their 20s, and they're going off to college or work. But for people who have really serious mental health conditions, they go about 10 years without treatment. And in that spiral downward, they become disabled. They become homeless. They have multiple mental health crises. I'm very hopeful for this administration. I think that Governor Pritzker made mental health and substance use a campaign issue. They increased spending for mental health and substance use very significantly this past year. I believe psychiatry rates, it will be announced very shortly that psychiatry rates went up significantly, but that's only one small piece of the puzzle. So I think that we have to be bold in what we ask for and what we push for to deal with the mental health crisis.
Yeah, I'd just like to add for the mental health crisis that we have a significant shortage in mental health providers and even people going into the mental health professions. If you look at the numbers going in just in residency programs, the numbers are dropping significantly. And for that reason, those providers that are available can command a very high price, as they should. It's what the market is bearing, but they tend then to go to areas that can pay that price. That oftentimes is not organizations that are safety net organizations. And again, these patients tend to be the most vulnerable. The other thing I'd like to say is that in terms of what you were saying, it does start in adolescence, and the number of providers then that are specialized or able to treat adolescents or children with mental health disorders is even smaller. So we have got to find a way to get people to go into this field and find a way to afford them in the safety net organizations.
Thank you. I think we'd love to open it up to questions and comments from the broader community. I think I see one hand up right now. Hi.
Yeah, and I should have said this earlier. If you'd introduce yourself and say where you're from or where you're working, we'd appreciate that.
Yes, good morning still. I'm Michael Gelder, and I don't know, where am I working? Not working. Not working at the moment, but I have been working, and much of what you're covering, and you guys did a very good job, raises about a dozen questions, but I know we only have time for a couple. So at maybe the more granular level, one of the things I was involved in probably 10 years ago was the issue of charity care in Illinois. And there was a major coalition of organizations, including Health and Medicine, of course, that worked to change the law and require hospitals to be both broader in terms of what their of eligibility and more transparent about who got it and how to get it, signs posted. That was supposed to, and then reinforced a couple of years later by the Affordable Care Act, raise every hospital's obligation to provide that charity care. It sounds though, from what you're saying, Jay, is that has there been we've forgotten about that? It's not being enforced. There are even more people seeking care through the charity care system. What do you think accounts for the failure of the system that was put in place legislatively to respond to the problem that we were experiencing a decade ago? And then my second question is, possibly broader, and I'd be interested in your comments. The idea of Medicare for all, of course, is to sort of normalize the delivery of health care so that there is no distinction between Medicaid and non-Medicaid or uninsured and Medicaid and non-Medicaid, that everybody gets health care with the card that they have in their pocket, as I now have a Medicare card in my pocket. What does that do to the safety nets, and how should we be thinking about it? Because we shouldn't just the goal is not to have a stronger safety net. The goal is to have access to high quality care for everybody. And we only have a safety net because our system has failed us for the last 50, 100 years, whatever it is. So how should we be thinking about preparing for a Medicare for all period, even if it doesn't come in the next election cycle? That is the direction I think that the arc of healthcare is moving.
Yeah, so to the first observation, Mike, I can't speak with a great degree of understanding about what the enforcement mechanisms that were put in, whether it's around HPTA or the community health needs assessments and so on from the Affordable Care Act. But what I can tell you is that the trend over the last handful of years has been for charity care to go down, spending-wise, overall, right? And so with more people covered, and this has happened both nationally, it's certainly demonstrable and it's measured by the state now, it has gone down overall in Cook County. The challenge has been for us that our charity care has gone up. And so it's very clear that for whatever reason, probably having to do with slimmer margins or other motivations, other healthcare facilities are walking away from their responsibility to do charity care, or they are shunting those individuals to our healthcare system. So our charity care has gone up by $104 million in the last 2 years, and it's unsustainable. I think to your second observation, the quick thing that I would say is that we are completely in favor of any strategies that will get us to enhanced coverage for more residents of the county and of the state. I think that what's going to happen then is, let's say that a wand is waved and everybody's got coverage tomorrow. I had a mentor of mine in Dallas who told me, that the day of universal coverage will be a day of reckoning for safety net institutions, because they'll find out how much people really love them. And I think that that's true, and this is a real challenge that we're seeing at the safety net, so-called safety net hospitals in the Chicago region. With the expansion of Medicaid, people have taken a card and said, I don't have to go to your place anymore. And they're going wherever they want, and they're going typically based on a real or a perceived expectation of a different kind of service, or they're going to try something different because they've had a bad experience someplace else. And so I think it's going to be invigorating and it's going to cause major disruption when it happens.
And I would actually just like to respond to the charity care question. Most people in the room probably don't know that I worked on charity care for about 6 years.
You didn't nail it, Heather.
I'm sorry. I tried. I think it's one of the most difficult issues in healthcare. I think since the Affordable Care Act came along and we had Medicaid expansion, it really fell off the radar. There is no enforcement mechanism.
Yeah.
And the hospital industry is very, very, very powerful. Every legislator loves the hospital in their district. And I also think, I was actually talking with an elected official a couple weeks ago at the state level, and she said, oh my God, that discussion was so antiquated. But I think what people don't understand is that the Cook County Health System is the safety net hospital that serves the vast majority of the uninsured in our region. And so charity care really falls on their shoulders, and there's no real funding mechanism that really deals with the full cost of providing it, and they don't have the political, what did you call it? You don't have any leverage.
Well, we don't have any leverage for enforcement. We'd like to think, and I think our board, I want to acknowledge Mike Ketting, who's here from our board today. Our board is trying to advocate for these things, but these things are going to require policy changes to be able to get the revenue. We're happy to do that work if somebody gives us the money to do the work. But expecting us to do the work without any money is unrealistic.
Hi, I'm Karen Larber. I'm the Director of Clinical Development for PhysIQ, and we're a tech startup company. And as I hear about the challenges that you've all reflected on, I wonder what the opportunity is for, specifically for technology, for innovation of different care delivery models, especially in a potentially value-based managed care market. And do you have the latitude or the openness to start exploring those at all?
So I can speak, and Dr. Cox-Batson can give a more close to it example of how this works, but I'll give you two quick examples of the use of technology in the health system. We helped to start some years ago a thing called MHN Connect, which allows enrollees in county care, if they register for care at an acute care facility, a hospital, an emergency room, that when they register, a message gets sent to their primary care medical home that they are in an acute care setting. And then when they're discharged from that setting, there's a flow of information around the problems that were addressed, if there were changes to medications or important lab results. That allows the primary care medical home to know instantaneously about that, and it gives them awareness, obviously, of what's going on with their patient, but it also allows them to more rapidly reach out and say, you've had an acute care event, we need to follow up with you quicker. You know, your next appointment was 8 weeks from now, but we're going to have you come in this week. The second example that we've used, and this is a shoot yourself in the head moment, is we've been using a technology called eConsult. And eConsult is a web-based platform that allows primary care providers in the community to send a request to one of our specialists saying, I've got this patient with such and such a problem, cardiologist, and this isn't working. What do you think? And within 48 hours, one of our cardiologists will look at that, say, I think you need to tweak this or test with that, and then see how it goes. Or they say, I think I need to see that guy tomorrow. Send him to the clinic. The shoot yourself in the head moment is we pay for it, we stand it up, we staff it with our docs, and it's not a billable service. And the utilization of it has been good, and it's helped to cut down unnecessary visits, so we think it's bringing value to the primary care provider and to the patient. But we also know that sometimes they'll say, oh good, that was good advice, patient's insured, the waits are long to get into your cardiologist, I'm gonna send them to St. Elsewhere. St. Elsewhere gets the benefit of a paid visit to a specialist after we initiated the cascade, if you will. So that's not getting back to the technology part, but we're trying to use those innovations, and we're trying to use the more global way that we get funding to put in some of these innovations, because that triple aim of trying to get a better outcome for an individual or a community is going to require those kinds of things, and we're able to do some of those innovations at scale. So.
Yeah, hi. Karen, I would say if you could just help all of these EMRs integrate, that's all we want. Yeah, just take care of that. No, really, I think from an IT standpoint, that is like, it's a very basic thing. For some reason, it's amazingly challenging. I mean, I think this is where our free market economy shot itself in the foot with the EMR, because if we had had just one EMR, then that would have been fantastic. But as it stands now, we've got all these separate systems that don't talk to one another. And anytime we want to create a mechanism to, for example, our organization would love to have a link directly to the county system, right? But to create that it's, you know, I'm not an IT person, but the barriers and challenges are extensive. So there's that. The other thing would be real-time decision support. I think that's the other thing physicians look for. Again, we're crunched for time, we're in a room, but we want up-to-date information. And yes, there is the up-to-date that we could go to, logging out and logging back in, but to have those things built into our EMR to help make real-time decisions is super, I think that's super important. And then, for example, with the e-consult that we were just talking about, that is a fantastic system. I will tell you the reason our providers do not use it as much as they should or could is because it's too cumbersome, because it's not in our EMR. So we have to come out, log in, go to a different system. Too much time, no one has it. Again, it's integration. We have got to get all of these amazingly independent platforms, they've got to communicate with each other, or else they're not really usable.
I think time for one more question.
Hi, thank you for your panel. So my question, two questions. One is about kind of related to housing, which is about like institutions and home and community-based services, and that there are a lot of people with health issues and disabilities who are unnecessarily going into institutions because there aren't any housing available after they've acquired an illness or something like that. There's not housing available. So like, what are you guys doing to address that issue, especially in relationship to the different consent decrees, Williams and Colbert and such, related to moving people out of institutions and into the community? And then my second question is about like diversity of the health profession. What's being done to make sure that healthcare professionals reflect more of the communities that they're serving, because that's a real issue and disparity. So like we keep talking about social determinants of health or healthcare disparities, but like nobody wants to say the word racism, which is what causes these things, or words, you know, or other isms. And so the mismatch, something that people of color, for example, have to go through is that the majority of the services that they will receive are from people that are not from their community, that are not from their culture, and that's something that's very stressful and contributes to bias and other health disparities. So like what is being done to help create like a pipeline to change that? Like we're at Loyola, so we have all these wonderful schools here, so you know, the boards of these hospitals don't reflect the communities that they're serving, and those are all contributing to these disparities. So what have you guys done or working on to help improve those two things? Thank you.
I can talk about both of those from Threshold's perspective. So Thresholds is one of the largest providers deinstitutionalizing people with serious mental illnesses under the Williams and Colbert consent decrees. I believe that we have deinstitutionalized people and returned them back to the community for I want to say about 1,200 people, and it is one of the biggest priorities of our agency. And as I mentioned earlier, we know that housing is really one of the biggest challenges that our population has. You can't very well manage any illness, whether it's a mental illness, whether it is a medical condition, whether you have a disability. You can't manage those if you're living on the streets or in unstable, unsafe housing. So we are working in coalition, hopefully this next session, with advocates across the state on housing legislation that is in development. So I don't have any of the details, but I'm happy to reach out to you or Access Living about that. And with respect to diversity, most of the people that Threshold serves are African American or Latino individuals, and a lot of our staff actually reflect that. And we do have a big effort at our board level actually to diversify our board, and that's been underway for quite a while. So I do think that there are organizations that are being responsive to the fact that we need to mirror the communities where we are and the people that we serve.
Yeah, I could probably talk forever about this, but in a sense it all comes down to economics, right? I will tell you that at Near North Health Service Corporation, our organization is a primarily African American organization. 75% of our patients are African American, about 20% are Latin American, and then the remainder cover the other groups. Our board of directors is primarily African American. Interestingly, we do not consider ourselves diverse because we're primarily African American, right? So it goes both ways. So we are actually looking to diversify ourselves by including other groups. So I just wanted to point that out. As far as what to do to get more people of color, POCs, as my 18-year-old children say, into the field, is, there's the Student National Medical Association, which you may or may not know is a primarily African American association. And then we partner with A.T. Still University in Arizona. It's a DO school in Arizona, and we're their medical campus, but they have started a program called Homegrown. And the whole point of that program is to go to underserved communities, select individual students that show promise, and mentor them through their junior high, high school experience to get them to the point where they are able and capable of applying for medical school. I really think that getting more people of color and more diversity into the medical field, it's going to start with the public education system, because ultimately you got to take the MCATs. Like you got to take the math, you got to do the chemistry. And until we get our education system up to par, we're not going to have the pool of people to pull from. So to me, it goes back to education. And then as far as getting people on boards and having boards reflect more the diversity of the community, I hate to say it, but it is a lot about economics. If you look at the major boards in the city of Chicago, there's very few people on those boards that are from really underserved communities, unless it's someone like Jonathan Rogers who has risen above. So it's about economics, and we've got to get our people in a stronger economic position, and then they will run in the circles and be at the cocktail parties and at the pre-meetings, as my husband says, because that's where all the business takes place. It doesn't take place at the meeting. It takes place at the pre-meeting that nobody knew about, and you have to run in those circles.
Thank you. Join me in thanking our panel for participating. We're going to take a quick second to transition into the third panel, so don't go too far. Alrighty, folks, we're going to go ahead and get started. So this is our third and final panel. If you can hear me, snap once. I don't hear the snaps. If you can hear me, snap twice. If you can hear me, snap 3 times. Great, we're going to go ahead and get started. So this third panel is a panel of advocates. And I'm really excited to be able to convene them as folks that I love and have worked with for a long time. But that being said, I think we're all familiar with the role of advocates in helping push forward change, and we see this panel as an opportunity to be able to touch on some of the things that happened last legislative season, but also really start charting out what's on the horizon through some of the work that these advocates have upcoming. So I think with that, really happy to introduce our panel. Thank you so much for the shushes. I appreciate not doing it. So I'm happy to introduce Nadine Israel, Vice President of Policy and Advocacy at the AIDS Foundation of Chicago. Stephanie Altman, Director of Healthcare Justice and Senior Director of Policy at the Shriver Center on Poverty Law, and Dan Rabbit, Senior Project Manager of Health Policy at Heartland Alliance. So join me in welcoming them to this panel. So the first question that I just wanted to open up to the three of you, right? We've heard so much this morning, both in terms of just the wide set of the research that was conducted by Health and Medicine, the two panels before you. Just wanted to ask you any general reactions that you have to the research and the comments that have been shared this morning. Anything that like is noteworthy that you want to call out for this group?
I can just give a couple quick reactions. Hi, good morning, everybody. So it was great to hear from the governor's office and from Corianne at DHS about their commitments to trying to improve our systems. And I would just encourage them to continue to push back against efforts from the Trump administration and elsewhere to use the fact that we're, having a hard time maybe in Illinois as leverage to push Illinois to implement policies that could harm people's access and could actually exacerbate the inequities and the complexities that we see today. So I just want to give them some credit for what they're doing and just encourage them to continue to push back and try to make the system better, and encourage all of you to help us in pushing them and nudging them to continue to do that as well. And I would also just echo just how complex and difficult some of this is, and that we really should do everything in our power to address that so that we can really use the promise of Medicaid and the Affordable Care Act and the great things that have happened to turn this around and really improve the healthcare system in Illinois and really improve people's lives. Medicaid is incredibly flexible and federal financing of it is generous, and we could do so many great things once we get our house in order. But we have some work to do, as you guys have heard so far this morning. So there's just a couple thoughts that I had.
Good morning, almost good afternoon. I need to stretch a little bit. It's been a long morning. Thanks so much for having me. I think it's great to see what we have experienced and kind of our lives and our professional and personal lives in research. So this is super helpful. There wasn't necessarily anything that is surprising to me from what was found from the research, but there is a lot of value in doing the research and putting it on paper. Some folks are convinced by a story, some folks are convinced by qualitative data, and some folks are convinced by quantitative data, and some folks need all of them and they're still not convinced, in which case we vote them out of power. And so I was really glad to see this, and I think we need to use this along with our stories and everything else that we know is true to make change. And so my hope is that the rest of my comments will be focused about solutions and what we can do, because while the problems are huge, if we really boil everything down, when we get sick, we want to be able to access the service that we need. And we want to also be able to access some preventative care so that we delay getting sick. So the more we simplify the systems on the back end, the easier it's going to be for all of us to do that. And Angel made a really good point that I just wanted to echo about the structure, the reasons why we are structured, the systems have been structured in the first place. It is by no mistake. It's structural racism that's been baked into all of our systems, including at our organizations. And we have to acknowledge that and say that out loud and continually work to undo it. And many of us are doing that. But we can't kind of sit and pat ourselves on the back and say, oh, we did a good job. AIDS Foundation of Chicago's board is more than 50% of our board is people of color. Great job. We need to keep going. We've got a long way. And it's not just about our board. It goes everywhere from our senior leadership team all the way down to the folks in case management. And I shouldn't say down, it's just like a spectrum. So I'll stop there and then let's see what Stephanie has to say.
I agree with everything that you guys both said, and also thanks to Health and Medicine for having this and also having us. It's true that the research that you do and the look that you give, not just to the patients and clients, but also to the providers, is really important. Without the safety net providers, without Near North, without Cook County, without all of these providers, our clients have nowhere. It doesn't matter if they get a card, it's useless. So access and quality healthcare, it goes hand in hand. I think that one of the things I would put forward solution-wise isn't any kind of like big long-term systemic solution, but just on the ground right now, there are questions about, you know, my clients are coming to me, I think, and patients and saying, I don't even want to be in Medicaid. Why should I do this? I can't renew. I'm waiting months to get a Medicaid card. So we're really fighting on the ground to make sure, as Corianne presented on this morning, that as DHS is working to improve their system and customer reliance, that we need to keep convincing people that it's worth it to be in these healthcare programs, because we're seeing such high rates of people not enrolling or falling off of coverage for many of the reasons that were mentioned today. But the data that just came out yesterday shows Illinois having one of the largest drops in children's insured coverage in years, and we used to be at the very, very highest in the nation. So part of that is immigration fears and public charge. Part of it is probably churn and some of the problems that exist in our bureaucracy, but we are helping people every day get onto Medicaid, and so we'll give you like that information, like the phone number we were talking about to get temporary cards and things like that. It does take some advocacy on an individual basis, but there are people like the Shriver Center and other places that are willing to help each and every provider with each and every patient and client to make sure they get on Medicaid as soon as possible while these systemic things are going forward.
Thank you. And I do want to take a second, right? I think just acknowledging, right, that a fair amount of the report, some of the comments, and initially in that initial panel really focused on redetermination, and as some of the advocates that have really been leading the charge in terms of working with the state to help improve and strengthen systems. I'm wondering if you can just speak to what's next, kind of like on ongoing efforts, like what was covered in the omnibus, what is next, what are opportunities for the wider community to continue supporting, making sure that there's like a comprehensive solution to the redetermination and eligibility problems in the state.
Sure. So first, the T card phone number, the temporary card phone number is 877-805-5312. So Stephanie and others know this way better than I do, but I believe if the application is older than 54 days, your Medicaid application, you call this number and say, my application is older than 54 days.
Press 8.
Press 8. Give your name and date of birth, and they should be able to look it up and say, okay, yes, we'll get your T card, Stephanie, within 48 hours. And that T card doesn't expire. So you keep getting, you get all of your regular Medicaid benefits for as long as, until you hear back from the state, whether you are, on Medicaid or not, whether your eligibility application went through or not. But it doesn't expire until that point.
It's posted on the DHS website, it's posted on the HFS website, it's on the notices. The phone number isn't on there yet, but they're putting it on. And we also can give Health and Medicine the connection for providers to join our Training and Technical Assistance Center, which is called Help Hub, where we have all of this there. We can help you if it doesn't work out with the client, and we also have a consumer fact sheet on it. Thanks.
Thank you, Stephanie. So if you call or somebody calls and tells you they're having a hard time, they didn't get it for whatever reason, please elevate it. I think our information is on here, but my cell phone number is everywhere. Okay, redeterminations. So a couple of things I want to say about that, and then just in terms of like what we've done and what we'll continue to do. One is that I liken a lot of these systemic issues, whether it's our historic underpayment when it comes to Medicaid rates, mental health, substance use treatment, but really most of our Medicaid rates, as was illustrated by the low per person per year reimbursement that we have for Medicaid in Illinois. It's historic. So it has been baked into our system for decades, not just a decade. And I liken undoing a lot of problems to like weight gain and weight loss. That's how I think about it. It's so easy, for me at least, to gain weight. I joke around that if I breathe like by Krispy Kreme, I'll gain 5 pounds. But it takes so much more work and time and effort to lose weight. And so it's easy to break down systems that are functioning, like what happened in the Ronald administration over those 4 years, or systems that were kind of hanging on by threads that were completely destroyed and dismantled by the policies that were moved both under Medicaid and other policies under that administration, and underfunding. But a lot of the issues that we've talked about today have been issues even before that. The Ronald administration just exacerbated those. Trump's policies are exasperating underlying huge issues that we've had in our systems. So it's gonna take us time, and we need to kind of continue to think of it as a marathon. That helps me a lot. It's not a sprint, but we can make change, and these are fixable problems. So very specifically with Medicaid redeterminations, there was a big bill called the Medicaid Omnibus Bill that passed earlier in this session. AFC, Heartland, Shriver, Angel, lots of folks in this room and not in this room worked together and advocated and negotiated with the state, with DHS and HFS and the governor's office to get some improvements to the Medicaid, the redetermination and eligibility processes into that bill. We were successful in some and we were not successful in others. However, one of the successes we had is that there's going to be a report, Ramon mentioned this, coming out. They said early November, so it should be any day now. I believe HFS and DHS have been working on the report. That basically part of that report is going to talk about, okay, here are the folks that within the Medicaid redetermination system that are going through a manual process, meaning they get a piece of paper in the mail, they have to fill it out, they have to do something, show some proof, and then send it back. That's the manual redetermination process. And there's a small sliver right now of people on Medicaid that go through an automated redetermination process. What we want to see is most people on Medicaid in Illinois going through that automated redetermination process. Because the reality is most people in Illinois and really in the US on Medicaid, their circumstances don't change enough for them to not qualify for Medicaid year over year. The homebound seniors example is a good example, but it's actually most people on Medicaid that fall on that. And so what we want to see as advocates, our Medicaid system move to is most people go through an automated redetermination process. That does not mean that the state isn't checking their eligibility every year. They are. They're just doing it through automated means, and they're not requiring the Medicaid recipient, me or somebody else, to have to say again that that information is accurate. So you roll over year, the state checks you year over year, but it's automated, it's not manual. So that report that's supposed to come out in early November is supposed to highlight, so who are the folks that are going through the manual redetermination process, and for what reasons? Like, why are they ending up in the manual versus the automated process? There's a couple other things that HFS has shared very recently that they're working on with the federal government to get kind of permission to do, which is which we were excited about because we wanted to see this in legislation and we didn't get it in legislation, but we're excited to see that the HFS is moving forward with it in a different way. So for right now, folks who have zero income, when the system checks them automatically in an automated way, if the system comes back and says Nadine doesn't have any, it doesn't look like Nadine has any income, and everything else is good in terms of my qualifications for Medicaid, I go through the manual process. And I have to send a piece of paper back to HFS that says, yep, that's right, I don't have any income, sign, send back. We know from our experiences that this process, this manual process, is why people are falling off. Something happens. They don't get their letter on time, somebody else gets their letter, they get their letter, it's not in the language that they understand, or it's in English and it's still not in a language that people understand. So there's lots of reasons why people fall off. So we call these folks zero income or no income folks. We want to see, and this is a good chunk of folks on Medicaid, especially Affordable Care Act. We want to see those folks go through an automated process. And so what we're excited about is HFS has said they are asking permission from federal CMS, Federal Centers for Medicare and Medicaid Services, to allow those folks to go through an automated process. Now, obviously it's a negotiation, we'll see where it goes, but we're excited that this is the state trying to do something positive and proactive, and this would have a pretty drastic impact if the state is successful on the redetermination issues that we've been seeing. Another piece that's a little bit smaller, but it does impact people that the state is my understanding that the state is working on, again, asking the federal government for permission to do, is so if you fall off Medicaid for redetermination reasons and then come back within 90 days, it's a little bit of faster process essentially. What the state is asking the federal government for permission right now is if you come back at any point in those 90 days, that you would go back to the managed care organization that you were in the first place. And what we've heard from most folks that we work with is that that's a good thing and people want to be able. So if I had Molina, Blue Cross, or County Care, I just want to get my Medicaid back and go back to my managed care, the one that I was in. And so, but there's federal rules that prevent that right now for that full time period. And so the state, again, is asking the federal government to allow that exception, which we think is a good thing. We wanted to see this in legislation. Again, we weren't successful there, but the state is working on it in other ways, which is wonderful. I'm really excited about the Medicaid redetermination hotline. Corianne said that that's coming out in the spring. I think that's gonna help as well. I would definitely encourage the state to make sure that there is looking at the Medicaid population in terms of language and having that same percentage of staff that staff the hotline speaking that language. So it's probably going to be Spanish is the, because with it, I speak other languages, translation services are not very, even though it's great and we need to have them, they're not very good. There's lots of different dialects and lots of languages, Arabic, Spanish, and other languages. And I've been on on the phone with translation services, and I speak Arabic, and I didn't understand what the person was saying. So I would just, especially language is so important, and it's an immediate barrier. If to people making sure that they understand what their paperwork is, know what to do, etc. I'm probably taking way too long already. Okay, let me stop there.
And I can just add something about Medicaid readies. I would just emphasize what Nadine said, that this is a long-standing issue. The integrated eligibility system that Corianne talked about that got implemented in 2017, that made it worse, but pretty much since we've been tracking Medicaid redetermination processing, between 1/3 and 1/2 of people lose their coverage at some period for some amount of time when their readies come up at renewal. That just creates a crazy amount of disjointed care and lapses in coverage that really impacts the healthcare that people receive and their ability to remain healthy, and just the amount of stress that they have in their life and the amount of stress that providers have in trying to run and try to figure that out. So addressing this is really important. I will say that this year in particular, in 2019, I feel like we kind of got over a milestone where I believe the General Assembly and the new administration, the Pritzker administration, understands that this is a problem. And so while we're trying the policy solutions that we have so far, this report's coming out, some of the things that Nadine mentioned we hope are gonna help. A key piece of this is just tracking it and seeing whether the numbers do improve. And if they don't improve, then I feel like we have ready partners in the General Assembly and in the Pritzker administration to try something else. I don't know that we have ready partners in the Trump administration, but we're going to do everything we can within the bounds of the federal rules and the federal partners that we have at the moment to try to get there. So progress hasn't been as quick as we would have liked. I think people are still falling off Medicaid far more often than we would like to see. It's still far too difficult to manage, to navigate the system. But I think we're heading in the right direction, and if we don't get there with the reforms we have on the table today, then I think we can continue to work with the state to get there in another way.
Thank you. Shifting gears a little bit, we've mentioned a little bit about just where the general state of attacks from the Trump administration largely falls on healthcare. And I think taking an opportunity to be able to forecast some present attacks and looming attacks, like specifically Texas versus Azar, changes to 1557 enforcement. Wondering if I can maybe ask Stephanie to give us an overview about what's going on there and potentially recommendations that you might lean on the state considering to help protect people in our state.
Sure. Thanks, Graciela. So you heard Ramon Gardenhire speak this morning about the commitment that the Pritzker administration has to fight back within the bounds that they can in terms of any sabotage of the Affordable Care Act. There's only so much a state can do, and there is a lot that the federal government is throwing at us. One of them was mentioned this morning by Olivia Quinones when she came up here, the public charge rule, and so she kind of gave a good overview of that quickly in summary. There's a lot of information on Protecting Immigrant Families Illinois, which is a coalition we're all a part of. And there is good training out there and good community information. But like I had mentioned before, we do think the chilling effect of the rule, as well as other attacks on immigrants just broadly, is causing what we kind of feared to happen. We weren't sure it would, but we are seeing, even in the most recent data for kids across the nation, but especially in Illinois and in other states with high immigrant populations, that Latinx children their insured status is decreasing. They are either disenrolling, not enrolling, or losing coverage at higher rates than other populations. One of the only reasons for that is most likely the immigrant fears. You should know that the public charge rule is right now suspended in what's called a preliminary injunction, which means that the federal government is enjoined from going forward. It was supposed to go into effect October 15th. We filed suit, as Livia had mentioned, representing ICER, Shriver Center, and Legal Counsel for Health Justice, but the Cook County itself sued as well. In that lawsuit, the judge ruled that the rule would be enjoined in Illinois, but in 3 other lawsuits, including one in which the Illinois Attorney General is a part of on behalf of the state of Illinois, 3 nationwide injunctions were entered. So I think it's 4 altogether. We don't know the timing. Those are preliminary. That means temporarily enjoined. So you can imagine how hard that is to get the message out to people when they already were really calling for the last year and saying, you know, things from ranging from, could I be deported if my kid gets Medicaid? What if I never can adjust my status? Can I never get a green card? What happens if I'm undocumented? Can I seek health care? From that to trying to explain some, you know, complicated legal theory that like, oh, well, we've sued the Trump administration and now judges have said it's temporarily can't happen, but we don't know, you know, if it'll ever happen. And if it does, it could even go back. And, you know, it's just almost impossible to message this in a way to give people comfort. And so we just try to talk to each individual person in each community and explain what's going on and what the risks could be for them if they are at risk. So that's what's going on in public charge, that there are other immigration-related rules and executive orders and things coming out. A lawsuit was filed today against, not by me, against the proclamation that the president announced 2 weeks ago that people would not be able to enter the United States on a visa if they couldn't prove that they had private health insurance. So a lawsuit was filed to try to enjoin that today. There's several others I'm sure Olivia could mention, but ICER is really leading the charge on this, as Olivia mentioned. But the real thing is, you know, there is good information out there, and really join PIF Illinois, Protecting Immigrant Families Illinois, in order to keep the most up to date. As far as Texas versus the US or Texas versus Azar, that's the case. It seems like Groundhog Day. We had, you know, the Affordable Care Act passed. Originally, suits were brought by largely Republican-led states to invalidate the Affordable Care Act. As you probably remember, the United States Supreme Court in those cases years ago, in that case said everything in the Affordable Care Act is constitutional, and it could go forward. The only change that was made, which is very significant, is that the Medicaid expansion, which covers Affordable Care Act adults, was made optional by the court. And so we have large states like Texas and Florida that are, for primarily political reasons, not affording coverage. After that, there were a few quiet moments to some extent, although the Republican Congress, after post
implementation of the Affordable Care Act in 2014, still did a lot of sabotage of it, and it really was never fully implemented as it was designed. The Republican Congress did a lot of things to continue to sue over it, to continue to stop money flowing into different parts of it, et cetera, but that really accelerated with the election of a Republican Congress and the Trump administration in 2016. Like, where are we now? In 2016. We then went through 2.5, almost 3 years of threats to repeal the Affordable Care Act completely by Congress. As you know, those failed. Ultimately at the last minute with, John McCain's up, down, or whatever. And, but the Republicans have threatened to, if they're in power again, to go back to repeal, and a second lawsuit has been filed. So that lawsuit now is winding its way up the courts, which is the one that you've mentioned. It's very similar to the first one. So you're like, how is this coming back to the Supreme Court? But it's basically saying now that the individual mandate, which required everyone to get health insurance, still is in the Affordable Care Act, but the penalty that people had to pay in their taxes is not, because Congress repealed that. The argument basically is that, well, we have to go back now and repeal the whole act. The whole act was like a puzzle, and if you take away one part of that puzzle, the whole thing falls. The U.S. Supreme Court kind of answered that the first time with the rejection of the Medicaid expansion as a permanent piece, but we have a different Supreme Court right now. So the case was decided first by a district court, which ruled that the entire Affordable Care Act is unconstitutional. So basically, the lowest court said goodbye. The court imposed a stay in that, meaning that the ruling wouldn't go into effect while there's appeals. It's now on appeal to the next level, which is the Circuit Court of Appeals, and we are awaiting the decision of the Fifth Circuit. We don't know what will happen. It should happen any day now, and it probably will be stayed again. So it's like kind of very, again, talking to consumers and communities, it's this, I think, as Ramon was saying, it's hard to continue to enroll people year after year when what they hear is, it's gone already, right? Or it's about to be gone, or, oh yeah, wasn't it already gone? And, I very famously or infamously, the day after the Trump election, before he was even in office or inaugurated, our Get Covered Illinois, which is our marketplace and Medicaid system here, we're getting phone calls the next day to the 1-800 line saying, I don't have insurance anymore. What do I do? Because, they reported people were calling because Trump said it will be gone the day I'm elected, and they thought it's something that could be gone. And that's not dumb. I mean, it's dumb he said that, but it's not dumb for people to believe it because, he said, he stands up now sometimes and says it's gone. We got rid of it.
He says a lot of things, so.
Yeah, that's true, yeah. But a lot of people believe him, apparently.
Yeah.
So we do a lot of talking to people and just saying, it's not gone. It's not gone, and oh, I have no idea. I mean, it will go to the Supreme Court most likely before the election, but we don't know if the Supreme Court will take it, for one. And we don't know if depending on the ruling of the Fifth Circuit, we also don't know what they would decide and when they would decide. The other thing is, what would Congress, even a Republican like Congress, do in the face of that? Because, it's, what do you call it, the dog who caught the car or whatever, it's really not what many of them want, yet it may happen in spite of them.
At one point, the Trump administration said it was not going to take it to the Supreme Court until after the election. But as you said, they say many things.
Well, and also I'm not an expert on Supreme Court law, but there is a timeliness of appeal, so you would have to appeal it within a certain time. I don't know that you're allowed to ask for the Supreme Court not to decide, so I don't know. But with the timing of it, I think it depends. It'll be hard. I know we're not at question time, so sorry. But I'm gonna leave it there. Yeah.
And maybe I'll take my moderator's prerogative just to make sure we have time for community questions and combine 2 questions. So this legislative season that just passed was a big season in terms of so many pieces of reform or pieces of legislation that help out with health reform or supporting people's health And some of those, I'll just list some examples: the needle and hypodermic access, Medicaid Omnibus. We've talked a lot about minimum wage, potentially allowing a graduated income tax. So when we think about what's on the horizon next for Illinois in terms of legislative efforts or ways that we might be able to support our state agencies, what are some things that you might want to pull out, either from wins that we've have already gained or things that are upcoming?
If I could just emphasize one key thing, I would say it is the ballot initiative for the fair tax, the progressive income tax, that's going to be on the ballot here in Illinois in November to amend the Illinois Constitution to allow a progressive income tax. All the things we're talking about, like so much of it comes down to disinvestment and lack of investment in public services and public systems. And we're not getting out of this. We're not ever going to have the financial flexibility as a state to properly invest in these programs unless we amend the Constitution to allow a progressive income tax, like I think 35 other states and the federal government also do. So I know that referendums, popular referendums, electoral things are not necessarily what this crowd always engages in. It's nonprofits, 501c3s, but 501c3s absolutely can. And we have networks and we have folks that we need to talk to, or that we have the ability to talk to and that we have credibility with. And it's our job is to make this connection of if you support Health and Medicine Policy Research Group, if you support Medicaid, if you support social services and the Department of Human Services, then you need to support the fair tax in November.
Fair tax. So vote yes on the fair tax November 2020. Talk to your friends and neighbors and board members and mail people and whoever about the fair tax and make sure they understand 97% of Illinoisans, 97% of Illinoisans, Jesus Christ, are going to either get a cut if we can get a fair tax in their state income taxes, or they won't see a change. The only people that will see an increase are the top 3%, and they should be paying more taxes in their personal income tax. If you care about the aging population, if you care about housing, if you care about food stamps, if you care about immigrants, if you care about Nadine, if you care about your mother, you should be for the fair tax and you should be working on the fair tax. The way to plug in, if you're interested as an individual or your organization is interested, all nonprofits can work on ballot initiatives. AFC is a nonprofit, so is Heartland, so is Striver, so is Healthy Illinois. And we're all working on the fair tax ballot initiative. So if your boards are having a hard time overcoming that, there are people that can come and talk to them and tell them exactly how to do that. John Bowman is one of those people at the Shriver Center, but there's lots of folks. Responsive Budget Coalition continues to exist and organizing now on getting the word out to everyone about the fair tax. We need a majority of the people voting in the election to vote yes in order for this to happen. We have been working together on this for 10 years. This is a structural revenue change that if we win, we will make huge changes to a lot of the underlying problems that we've been talking about. So if we do nothing else between now and November, we should be talking about the fair tax in every interchange, every conversation that we have. So like I cannot stress that. Everything that we talked about, I cannot stress that point enough, honestly. Census 2020, I can't leave this without saying Census 2020. We need everybody counted. I've already started getting calls from like friends and family being like, do I really have to do this? So we want to make sure that we're doing what we can as individuals and our organizations to get the word out, to get counted, complete the census, and voting.
Thank you, Nadine. And I think that was a really quick rundown, right? I think just acknowledging we're not just a conversation-based table, we're like an action-oriented table. So just any last-minute recommendations on ways that folks can engage and support reform, like you've listed a couple of ways that folks should support the fair tax and the census, voting, but any other ways in terms of legislative efforts ways that folks can support reform.
I guess I'd be remiss to not mention the Protect Our Care Illinois coalition that we're all a part of. And I think many of you are probably aware of it, but that is a statewide coalition that's dedicated to protecting the Affordable Care Act, Medicaid, and building on them and building a healthcare system that provides universal coverage and affordable healthcare to all. That coalition is a great way to get plugged in if if you are not so plugged in into what's going on at the state or federal level and want to stay up on health advocacy issues, you can talk to any of us about how to plug in. But I think that coalition really serves to help mobilize not just policy analysts and wonks up here, but folks out in the community. So would encourage you guys to look that up and get involved. One campaign that Protect Our Care Illinois is taking on next year is prescription drug affordability. We talk so much about coverage, and as well we should. Coverage is key, but even having coverage doesn't necessarily mean affordable healthcare. And we've seen that it's actually getting worse over time as high deductible plans and the high cost of prescription drugs continue to tax people more and more. So that's something we're going to be working on, and looking forward to sharing more details about that with you soon.
So I think with that, why don't we open up for questions from the broader community? I see a hand up already here.
Hi, everybody. I'm Julie Hamus. I used to be at HFS, and now I'm at the Office of Medicaid Innovation. We really support the Medicaid program, and I wanted to just alert you to what I consider service delivery reform coming right up in the next year. In the area of behavioral health transformation, I mean, we already talked about, and I think Heather always makes an important point, that providing enough services and access to services is still an issue. But I think it's important to know that there's going to be a lot of work to create new services in Illinois, to create new behavioral health provider types in Illinois. And also what I really want to alert you to are these integrated health homes. So there's been, like we've been talking about it for a long time, but it's really going to happen. And integrated health homes, and what's important for you all to know, again, misnamed, they really are care coordination. It's about care coordination. And I think what this new administration is rolling out are two very different models, one for adults with behavioral health care needs and one for children. Very different approaches. First of all, they're really pushing Medicaid managed care companies to contract with community providers for both of those. So there's a sense that for the people with serious behavioral health care problems, the care coordination has not been good enough done by the MCOs. So community providers will have a real opportunity to emerge as being more in touch with their communities. And for adults, the concept is to hire what are called like engagement specialists. I call them community health workers. You know, it's a type of, it's a person with really, I don't even know what the education type is. I think it's people from the community are intended to be these folks, and to really engage people to come into the healthcare world. And they need to know the community, they need to know the people who are now hidden to the healthcare system. So there's an opportunity, I think, to create a whole new group of folks who really are very much on the ground and in touch with their communities. For children, it's almost like the opposite. We're going to be training specialized care coordinators in high fidelity wraparound, it's called. It's a system of care model. It's nationally recognized. And what's really compelling about this, it's going to be a very low ratio between the care coordinator and the number of children that they're responsible for. So that makes a huge difference, as you all know. That ratio is key. So again, if you know providers, if you are those providers, please be alert to some real opportunities here to do some very important work. And it's going to really, I think, emerge in the new year. I think the launch date is intending to be April 1st.
Do we have other questions from the audience for our panelists? Don't get shy now.
Margie
Archie Shaps from Health and Medicine. I think it was you, Nadine, but I'm not positive. Somebody was talking about that Illinois had the greatest number of kids disenrolled in the last year. Stephanie, can you talk a little more about why that is, Stephanie, and what are we doing to address that specifically? Because that seems like the easiest population to address.
You would think so. It's always a population that we had very high enrollment numbers. At one point, we were number one in the country. We were at almost 98% of all kids insured. So we're not sure of the reasons for the drop-off as part of it. Because the rates are so high in Latinx children, it's a logical conclusion to think that some of that is immigration first and public charge. Now that we're seeing the data, it's a 2-year data set. It's on the front page of the Shriver Center website. If you go to our press room, we put out a press release about it yesterday. The report is a nationwide report done by Georgetown University Center for Children and Families. It usually gets press, but it got a lot of press yesterday. So it was on CNN. Hillary Clinton retweeted the national study. And Illinois is just one of the highest states, along with states that you may expect more, like Texas and things like that. But we do think the churn rates here and the problems with the integrated eligibility system and the bureaucratic kind of red tape, as well as the budget impasse, because this looked at 2016 to 2018, definitely had a lot to do with it. Here in Illinois, it's not all public charge in immigration, but it's really worrisome. And I think the highest increase or highest rate was at the 138% of the poverty to 250% of poverty, just kids on CHIP. So, we're really not sure, because that's an uninsured rate. It's not just them moving on and off of Medicaid. They're not getting covered anywhere else. So we're digging in.
Michael Gelder, on that, just to follow up on that. So, as I looked at it yesterday very quickly, these are fewer people eligible for Medicaid, right? Rather than are these people that were on Medicaid, and we know those individuals who were on Medicaid are no longer on Medicaid and they didn't go somewhere else.
Both. So our Medicaid numbers have gone down. I mean, it's apples and oranges, but our Medicaid enrollment has gone down. But also, thank you, the overall uninsured rate has gone up. So we know they're not going somewhere else based on that insured rate. But Medicaid rolls are going down too, and that's not explained completely by people getting to higher income levels when you look at the rate. So it's got to be a combination.
Although when we were in state government, in the recession, I mean, Medicaid is intended to be counter-cyclical. So as the economy goes down, Medicaid rolls go up. You would think that to be counter-cyclical, you'd also have the opposite phenomenon, that when the unemployment rate goes down and employment goes up, Medicaid enrollment goes down.
Yeah.
Is this not?
People?
Why do we think that's not a?
I don't know. People have looked at it, but and I can't remember right now looking at some of it. But even though employment has gone up, it doesn't explain the corresponding income levels. The number of kids in those income categories have not gone up in the same correlation as you would see. So Rob Perel, who does a lot of data on this, has looked at it, but it's not just the getting employed part or the economy getting better. You'd have to see kids in those categories at those percentages of poverty going up. So if we saw children going up from 130, family income from 138 to 250, et cetera, you would think that would make sense, right? They'd be going off, but we're not seeing as many kids as are dropping off of Medicaid. The same number of kids aren't going up in household income. So
and just most clearly, employer-sponsored insurance, ACA insurance, is not going up. So it's not that you're getting a job and now you have employer-sponsored insurance, and so your kid comes off Medicaid. Just the total aggregate number of kids without insurance has gone up 400,000 or something in the last 3 years. And that's not explained. If people,
with the country.
If people are getting new jobs and better jobs, those jobs are probably going to have health benefits for your family, or you're going to stay on Medicaid. And that's just not
especially in Illinois, because your premiums are pretty low and you can be up to almost 70,000 for a family of 4. So if our income levels weren't that high, but we don't know. I mean, I know HFS and DHS are looking into it. It could be some drop off of people not wanting to pay premiums at the higher levels of all kids, but leaving their kids uninsured. But when we've talked to the state, they think a fair amount's due to churn and possible immigration. Not necessarily, I mean, they have not given a reason of kids' poverty levels are going up so far, but I mean, we don't.
We probably have time for one more question. Or do we have any closing comments from any of our panelists? Anything you wanted to address that you didn't get to?
Yes.
Fair tax?
Fair tax, no.
You could tell them about fair tax.
No.
You address the other thing.
So when we're talking about public option or Medicaid buy-in or whatever it's called, I just want to like re-emphasize the Medicaid redetermination and eligibility issues must be fixed first before we do anything, before we build. So if you think of it like a house, our foundation, getting on Medicaid and keeping Medicaid benefits is the foundation of the Medicaid program. We need to fix that first as a state and make sure it is functioning before we build on it. And so whatever we're building, the part of that conversation, whether it's a task force, a report, more policy changes, more money, needs to incorporate fixing the Medicaid redetermination and eligibility issues and getting real-time eligibility and getting folks renewed automatically for the most part, automated redeterminations. So I just wanted to emphasize that because we're going to be hearing more about public option or Medicare buy-in or Medicare for all, and we really need to make sure that we are taking care of this dramatic issue that we have had in Illinois for at least the last 7 years, and fixing it before we build on it. The other thing that I just wanted to highlight is community health workers. There's actually, Julie brought up the community health workers. There's something that we can do. So Health and Medicine has led on and many others, not me, on the community health workers issue in Illinois for years. There's a report that we can dust off the shelf, that the governor's office can, we can as advocates, and take it to the legislature and say, Medicaid should be reimbursing community health workers. And or we need a new state line item in the budget that pays for community health workers. These are folks, Margie, please. Yeah. No, that's it. I was just gonna, that's it. That's all I got.
Well, I do want to address that, which is to say there is a new task force that has taken the old report and is now dusting it off and saying, how can we update this? What's going on around the country around community health workers? And that's going to happen over the next 6 months. So there'll be a report out probably in April. If anybody wants to plug into that, get in touch with me.
Great. Well, I think that's the close of our event. Can we have a round of applause for our great panelists? Great. Well, thank you all for coming. We will be sharing out resources from today that were shared in your packets and also an evaluation. I hope you'll fill it out. Thank you again for coming. We hope to see you again soon.
Thank you.